infection is basically caused by pathogenic organisms. When any pathogenic organism enters the human body, it can produce a reaction. If the human body overpowers it, then it produces no disease or symptoms. But if the infection takes, if the bacterial or viral or parasitic, whatever it may be, it overpowers the human responses, it can produce a disease. So that is broadly. Now, what the hell do we have in surgery? We have antibiotics, we have antivirals to treat infections. Then why are we so concerned about infections as a surgeon? Hey, next slide. এটা ওকে, এটা কিভাবে উঠবে পুরোটা? Okay. Basically, we as surgeons encounter three types of infections. Number one is infections arising as a result of surgery. Number two is infections that need surgery. And number three is healthcare associated infections. These rarely need surgery, but we often have to treat them. Okay? Now let us come one by one to all of this. This is such a topic that this is one such topic that if we start, it will never end. Now, infections arising as a result of surgery is defined as infection at the site of surgery if it must occur within 30 days of surgery if there is no implant. But mind you, if there is an implant, it can occur within 1 year. For example, a patient has a fracture of right forearm. We treat the patient with a screw plate like all those things, and that implant gets infected. That is also surgical infection. Or we treat a patient with a patient has a complete heart block. We insert a permanent pacemaker. The pacemaker gets infected. It can also happen for a heart valve surgery, the valve replacement, and the patient develops infective endocarditis after that. Okay? These are all prosthetic and they can occur up to 1 year after surgery. Okay? Am I clear with the definitions? Now, surgical site infection এর আগে আমাদের যেটা যেতে হবে, that is classification of surgical wounds. Classification of surgical wounds. Classification of surgical wounds একটু তুলে দাও, is of 4 types. Number 1 is clean. What do we mean by a clean wound? A clean wound is a wound which happens when we do a planned surgery and there is no contact or contamination or breach of the respiratory tract, of the alimentary tract, and sterile urinary tract and the genital tract. As we all know, in our respiratory tract there are millions and billions of pathogens and bacteria. Every human being's alimentary tract has millions and billions of bacteria. So if they are not breached, it becomes a clean wound. Am I clear? If you face any difficulty, please interrupt. Okay? Number 2 is clean contaminated. What the hell is this? I am calling something clean and calling something contaminated. Isn't it a misnomer? It is. But it is a bit different from clean wound. Just like a clean wound, but here we are breaching any of those systems, the respiratory, the alimentary, or the genital system under clean conditions, like an appendectomy. What happens? After securing the base, we sever the appendix from the base, isn't it? We cut it. And the lumen, it contains bacteria. But there is no spillage. There is no spillage of contents. This is clean contaminated wound. These are almost always result of planned surgery. And that clean contaminated becomes contaminated when there is already perforation of a hollow viscus, like it may be peptic perforation where the stomach or duodenum has a perforation. It can be appendicular perforation with release of all its contents into the peritoneum. So when we enter, how many bacteria we can separate or clean off? There is bound to be some contamination. That becomes contaminated wound. And the fourth is, the fourth is dirty infected. What is dirty infected? A patient suffers a trauma there in the road. His hand is broken. The bone edges are exposed. Dust, dirt, everything has gone inside. That is dirty infected. Am I clear? After that, let us come. So this is the classification of surgical wounds. After that, we come to classification of surgical site infections. The classification is broadly into three groups. Now, superficial incisional, deep incisional, organ space. SSI is the short form surgical site infection. Okay? What is superficial? It involves the skin and the subcutaneous tissue. What is deep? It involves the muscular layer, with or without involvement of the superficial layers. So suppose, think of the abdominal wall. After skin, we get the superficial fascia that has two layers, fascia of camper and fascia of scarpa. Then we have the deep fascia. Then we have the muscles. Then we have the parietal peritoneum, isn't it? The layers of abdominal wall. So when the skin and subcutaneous tissue is only involved, it is superficial incisional surgical site infection. When the deep is involvement of the muscular site with or without involvement of the superficial ones. Okay? And number three is organ space. Organ space. What is this? Organ space surgical site infection is infection of a specific organ related to the surgery. For example, after appendectomy, the patient develops an abscess. Or after open cholecystectomy, the patient develops an abscess in the subphrenic space. That is between the liver and the diaphragm. That is organ space. Okay? Am I clear? Okay. Now, which patient is going to develop this? Not everyone is going to develop surgical site infections. If all patients develop, then we have to search for a new job, because we will be beaten up by the patient party in nowadays environment. There are factors can be classified into three groups: patient factors, environmental factors, treatment factors. What are the patient factors? There are lots and lots of patient factors. Next slide. Alcoholism, ascites, age. Alcoholism, ascites, age. What is age? High age. Or even in extreme low age, it can also happen. Extremes of age is rather more obesity. Of course, I am more likely to develop any infection than her. Why? Because beneath the skin there is fat, and fat is devoid of blood supply. Am I clear? So when there is devoid of blood supply, the medicinal elements are unlikely to reach there. How the medicines reach? You administer oral antibiotic or IV or IM, whatever you do, it gets absorbed into the bloodstream and the blood sends there. And fat has no proper blood supply here, subcutaneous fat. So then chronic inflammation. Any chronic disease lowers the immunity. Any chronic disease. It can be tuberculosis. It can be HIV. We all know HIV is an immune deficiency. It can be tuberculosis. It can be any malignancy. Then diabetes mellitus. How diabetes can cause infection? Actually, diabetes is one of the biggest killers in humanity. It kills all. It doesn't kill suddenly, usually. It kills slowly. It causes three things. Number one, it can cause neuropathy. What does that neuropathy means? The nerves get destroyed. Diabetic neuropathy. What happens? When the nerves get destroyed, the patients do not feel trivial trauma. Okay? They suffer cuts, bruises, infections. Next is, next is, yes, what you are saying. That is, they cause vasculopathy. That is, the blood vessels get clogged. That means there is deficient blood supply. Infection takes longer time to heal. And number 3, the high sugar containing blood is a very good food for bacteria. That heightens the chance of infections. Okay? Then history of skin and soft tissue infection. For example, if I am doing an appendectomy today and the patient is having a carbuncle here, I am entering the abdomen by cutting through an infected thing. Chance of infection is obviously high. Hyperbilirubinemia, hypoalbuminemia, next slide. Hypercholesterolemia, hypoxia, immunosuppression, malignancy I have already told you, malnutrition, anemia, peripheral vascular disease, diabetes, one of the causes of diabetic infections, pre-existing infection, recent radiotherapy. Particularly, it happens in cancer patients. Next is smoking, steroid therapy. We all know. Have you read about steroids in pharmacology? Yes, they are immunosuppressive. Yes, they are. Now the environmental factors. Contamination. As I have already told you, a road traffic accident patient coming out. Then inadequate antisepsis. Our OT is not sterile enough. We face it day in, day out. Number 3, inadequate disinfection of the material. Inadequate operating room ventilation. That is also a very important risk factor. Increased operating room. Yes? Next slide. Oh, sorry. Thank you for pointing it. Thank you. আমি এখানে স্ক্রল করছি তো আমি ভাবছি স্ক্রল করা হয়ে গেছে সরি আচ্ছা ইনক্রিজড অপারেটিং রুম ট্রাফিক একটা ওটি চলছে 10 জন খালি ঢুকছে বেরোচ্ছে যেটা আমাদের দেশে খুব কমন that also causes last are the treatment factors that means factors related to the treatment of the patient contamination next slide emergency surgery, placement of surgical drains, hypothermia of the patient, poor optimization of the patient prior to surgery. একটা পেশেন্ট আমার কাছে এলো 300 ব্লাড সুগার, এই পেশেন্টটা যদি ভেগে যায় কালকে ওটিটা করে দিই, সুগারটা কন্ট্রোল না করে আমি ওটিটা করতে গেলাম। আমরা তো করি, after all we are all humans and we are all greedy, isn't it? Prolonged operation, yes. Operating time has a role to play. The longer you operate, the chances of infection is higher. And inadequate or inappropriate antibiotic therapy. We will come to it later on. Pathogenesis of surgical infections. It is a very, very weird, detailed thing. I have just tried to finish it in one paragraph. Because any surgery of any type can cause immunosuppression, and it causes severe immunosuppression. But whenever we do a surgery, what is surgery? I am cutting through this. If someone stabs here, that becomes an injury. And I am now cutting this. This is also injury. The difference is that is unplanned, this is planned. Surgery is a planned infliction of a planned wound. So whenever we cut it, we all know whenever there is attack on the body gives rise to inflammation. From your pathology knowledge, you must be reading that. And this inflammatory response is the most important part of healing. This is usually sterile, and the host defense mechanism controls it. But at the same time, a few other things also come into play. Like tumor, like various interleukins, the various tissue plasminogen activators and all those things, like alarmins they are also called, they also come into play. And if this overwhelms the immune body, the sterile inflammatory response of the body, they can cause severe infections. That is in broad, in gist, the pathogenesis. Do you want to ask anything regarding this? Are you clear? Microbiology. It can be viral. The next slide. Next. It can be Streptococcus, Staphylococcus, Clostridia, Clostridia and perfringens. आजकल दिन आप देखा जाए ना gas gangrene. Next is Clostridium tetani, can cause tetanus. Clostridium difficile, it can cause pseudomembranous enterocolitis. Aerobic gram-negative bacilli, E. coli, Klebsiella, Pseudomonas, bacteriids. Okay? These are the common bacteria. Next is clinical features. Next slide. Purulent discharge from the wound. This is the hallmark. Features of inflammation around the surgical wound. What are the features of inflammation? Calor, rubor, dollar, tumor, functional lesion. পড়েছিস তো? Semester হয়ে গেল তো, তাহলে তো এগুলো ছিল। Then drainage of infected material from the drains if there is deep organ specific. শুরুতেই বলছিলাম 3 types, superficial, deep and organ. If there is organ or space, drainage of infected material from the drains. Features of systemic sepsis. When these are overwhelmed, the bacterial count is very high. Systemic sepsis, hypotension, high rise of temperature, hypotension, shock. Okay? These are the clinical features. Now there is this. This is a big slide. Classification of surgical wounds on the basis of infection. Grade 0, normal healing. No sign of infection. Grade 1, with mild bruising or erythema. What is erythema? জোরে বল এরিথিমা হচ্ছে রেডনেস, 4-5টা রেডনেস লালচে হয়ে আছে। আচ্ছা, এবার গ্রেড 1 এ সাম ব্রুজিং, 1B কনসিডারেবল ব্রুজিং, গ্রেড 1C পরিষ্কার বোঝা যাচ্ছে সিট থেকে, 1C মাইল্ড এরিথিমা। Number 2, grade 2, it is erythema plus other signs of inflammation. 2A at one point, 2B around the sutures. প্রত্যেকটা সুতোর পাশে পাশে দেখবি পাস পয়েন্ট হয়ে রয়েছে। Number 3, around the wounds, গোটা উন্ডটাকে ঘিরে পাস পয়েন্ট রয়েছে। Number 4, along the wound or around the wound. Number 2C and number 2D. Then is 3, class 3, that is clear or hemoserous discharge, that is blood stained serous discharge. গ্রানুলোমা তো এখন নয়, এরিথিমা প্লাস আদার সাইন্স অফ ইনফ্লামেশন রয়েছে ওখানে। অ্যাট ওয়ান পয়েন্ট থেকে যখন আমার এরিথিমা আদার সাইন্স অফ ইনফ্লামেশন একটা পয়েন্টে, দ্যাট ইজ 2A, মাল্টিপল পয়েন্টস 2B, অ্যালং দ্য উন্ড 2C, চারপাশে অ্যারাউন্ড দ্য উন্ড, ওটাকে ঘিরে চারপাশে ইনফ্লামেশনের ফিচার রয়েছে, দ্যাট ইজ 2D। 3 ইজ ক্লিয়ার অর হিমোসেরাস ডিসচার্জ, আবার সেই একই কথা, at one point 2 centimeter or less in size, that is 3A, along the wound more than 2 centimeter, that is 3B, large volume এ বেরোচ্ছে। The definition of this large volume is not specified here in this classification, so it depends on the surgeon concerned at least, but standardly in other cases in drain outputs usually more than 100 ml is considered large amount. Okay, then it is persisting for more than prolonged 3 days or more, then that becomes 3D. Then grade 4, pus, 4A, at one point only, again 2 centimeter or less, 2B more than 2 centimeter, And number 5, deep or severe wound infection without tissue breakdown. Okay? This is classification and the basis of infection. Okay? Now, treatment. Identify the organism, very simple. Culprit ke chor ke dhorte gele chor ke age identify korte hobe. Next is swabs. Send them for culture and sensitivity. Next is start broad spectrum antibiotics. Now, how to do it? আমি তো কালচার পাঠিয়ে দিয়ে কি ওয়েট করব? পেশেন্টের এদিকে জ্বর আসছে, গন্ডগোল হচ্ছে। Then here comes the role of microbiology. প্রথমে বললাম কমন ব্যাকটেরিয়া। এবার মাথায় রাখতে হবে কোন অপারেশনে কোন ব্যাকটেরিয়ার রোল কতটা। Clear? For example, when we are dealing with gut, E. coli and Pseudomonas are the more common infections. So we have to think about coverage, antibiotics that covers these. But when we are operating, say, like hernia, superficial surgery, or any orthopedics, the chance of contamination, unless it's an open wound, is very less. But gram-positive staph or Streptococcus is the more important. So we have to think about antibiotics covering them. So selection of the empirical broad-spectrum antibiotics. So it is best what to do? Start with one antibiotic that gives coverage, blanket coverage to all those suspected pathogens. Okay? আমি জানি না কোন দিক থেকে অ্যাটাক আসবে, আমাকে এদিকেও একটা পাহারাদার বসিয়ে দিই, ওদিকেও একটা পাহারাদার বসিয়ে দিই, দ্যাট ইজ বেটার। এবার যখন জানলাম না অ্যাটাকটা ওদিক থেকে আসছে, তখন আমি এদিকের পাহারাদারটাকে দিয়ে ওদিকে পাঠিয়ে দিলাম, যাও রিইনফোর্স দ্য ডিফেন্স অফ দ্যাট সাইড। That is normal policy, isn't it? And that should be our policy. Now, localize and drain the pus. Kirokom? For example, amake puchta bar korte hobe. What is pus? What is pus? Dead WBC. যুদ্ধ ক্ষেত্রে নিহত সৈনিক, সোজা বাংলায় যুদ্ধক্ষেত্রে নিহত সৈনিক। আজকে ধর ইন্ডিয়া পাকিস্তানের যুদ্ধ হলো, ইন্ডিয়া জিতলো, কিন্তু সেই জেতার জন্য বেশ কিছু ইন্ডিয়ান সোলজারের প্রাণ যাবে। নাথিং কামস ফর ফ্রি। মহাভারতের যুদ্ধেও পাণ্ডবদের প্রচুর লোক মারা গেছে। তার মানে কি? এনি ওয়ার ইউ উইল লুজ সাম অফ ইয়ার্স, এভরিওয়ান লুজেস সামথিং। When there is a problem in the body fights it, certain number of WBCs actually die. Pus is nothing but those collected WBCs. And when there is pus, there is chance of infection is very high. They are almost always infected. Because the vector is the bacteria that is also present there. So you have to drain the pus, take out the pus, either by surgery or by image-guided percutaneous drain placement. একটা সময় ছিল সব অ্যাবসেস হলে আমরা অ্যাবসেস মানে ভর্তি করো, এখনই কাটবো। অ্যাপেন্ডিকুলার অ্যাবসেস হলে অ্যাপেন্ডিক্সের জায়গা থেকে অ্যাবসেসটা বার করে দেওয়া, সাবপেডিক। এখন কি হচ্ছে? ইউএসজি অ্যাপেন্ডিকুলার অ্যাবসেস বড়, ইউএসজি গাইডেন্সে একটা ছোট্ট ড্রেন ঢুকিয়ে দিচ্ছে ইন্টারভেনশনাল রেডিওলজিতে। সো আইদার ইমেজ গাইডেড অ্যাসপিরেশন or by open surgery or laparoscopic surgery, which one is suitable. Next is debridement of devitalized tissue. That is very important. Dead body রাখার কোনো জায়গা নেই, ঠিক আছে? যে টিস্যু ডেড তাকে নির্মম ভাবে ছেটে ফেলো যতক্ষণ there is clear bleeding. Clear? Gangrenous tissue must be excised, because if they persist, they will stay there as a needles for further infection. Treatment, timely antibiotic de-escalation. What is this? I have told you first, culture sensitivity. Start with broad spectrum antibiotics. Now you de-escalate. As the patient improves, de-escalate. Adequate supportive care in septicemia and SIRS. What is SIRS? Systemic inflammatory response syndrome. Okay? Adequate supportive care. Majority of these patients have hypotension. So you have to give them inotropic support. What is the cause of hypotension in these patients? Severe vasodilatation due to endotoxins. Endotoxin mediated vasodilatation. So you need vasopressors to treat them. What are those vasopressors? Dopamine, dobutamine, noradrenaline. Noradrenaline infusion is the treatment of choice of hypotension. For hypotension is systemic sepsis. So this supportive care. If the patient is having lung problems, supporting with oxygen, no response, start BiPAP, no response, go to invasive ventilation. Clear? This supportive care is very important. And last, regular wound dressing. Clean it. What is the idea of dressing? Clean it, clean it, clean it. Am I clear? This is the treatment. Now comes the most important thing. How to prevent it? How to prevent it? Preventing it is a problematic thing. But we must try. Nothing is perfect. You cannot prevent it totally. We cannot eliminate it, but we can minimize it. So, pre-operative preparation. It starts from there, not from the operation. What? There is a certain thing is, what is that? Have you seen, I have written a word here, MRSA. Do you know what is this? Methicillin resistant Staph aureus. It's a very deadly antibiotic and a deadly infection. You have already heard of one thing about nosocomial infection and community acquired infection? Yes? Yes, that is called nosocomial infection. Nosocomial infection has a big role to play in SSIs. A short pre-op hospital stay lowers the risk of acquiring MRSA. This has been found in certain studies. Optimization of the patient, that is, control the hypertension, control diabetes. If the patient is having cardiac ailments, try to control it. If there is albumin deficiency, correct it. If there is anemia, correct it. Optimize the patient. But don't forget, this is not always possible. Why? For example, I am the surgeon on the call today here, so for example, and suddenly a patient comes with a bullet injury and he has a blood sugar of 600. Okay, let me control the sugar, then I will operate. Okay, by the time the sugar is controlled, he will straight go to the funeral center. That is not desired. We have to operate that patient, taking the risk. Am I clear? Then is wash hands. This is the single most important step. Washing your hands. And believe me, ideal teaching says wash hands after coming in contact with every patient. The fact is we don't do it. We know it, we don't do it. এই আউটডোরে তোরা অনেকেই আমি দেখেছি আউটডোরে ক্লাসে গেছে, সব কটা পেশেন্ট দেখে দেখে আমরা কি আর উঠে হাত ধুই? বা ওয়ার্ড রাউন্ডেও দেখেছিস সব পেশেন্ট টাচ করার পর কেউ কি আর গিয়ে হাত ধুচ্ছে? But this is important. It has been proven beyond doubt this lowers infections. And also it protects the healthcare professional from also acquiring hospital-acquired infections. Next is, and no, it is not only for doctors only. It is for each and every hospital staff. Mind you, একটা পোস্ট-অপ পেশেন্টকে একটা ডাক্তার যত না দেখে তার চেয়ে অনেক বেশি দেখে অন ডিউটি নার্সিং স্টাফ। তার জন্য এটা প্রযোজ্য। Wash your hands after every patient contact. Clear? Staff with open infected wound must not enter OT. Period. আমার আজকে অপারেশন আছে, আমার এখানে একটা বাজে কাট হলো, বাজে উন্ড হয়ে রয়েছে আগে থেকে ইনফেকশন, আমি করব না অপারেশনটা, অন্য কাউকে দিয়ে করাতে হবে আইডিয়ালি। কিন্তু প্রাইভেট সেটআপে কাজ করি, অন্য কাউকে দিয়ে করালে পয়সাটা তো আমার পকেটে আসবে না, আমরা করেও ফেলি। ইটস দ্য ফ্যাক্ট। প্রি অপারেটিভ শেভিং, অপারেশন আগে শেভিং হয় দেখেছিস? যারা ওটিতে গেছিস দেখেছিস? শেভিংটা আগের দিন বা বাইরে করার জাস্টিফিকেশন নেই। কেন? 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 এই প্রি অপারেটিভ শেভিংটা আগের দিন করার জাস্টিফিকেশন নেই কেন? কি হয়, যদি যত ভালো করেই শেভ কর, কিছু ব্রুজ হবেই, ব্লেডের ঘষায় কিছু ব্রুজ হবেই, মাইক্রো হেমারেজ হবেই। দ্যাট অ্যালাউস ব্যাকটেরিয়াল কলোনাইজেশন, যার জন্য বলে it should be done immediately prior to the OT in the operation theater. প্রবলেমটা হচ্ছে আমাদের দেশের ডাক্তারবাবুরা তো বিগ ইগোইস্টিক, কি আমি লোকের কামাবো না, কামাবো না, উই ওয়ান্ট ডু ইট। এই আমাদের দেশে আগে থেকেই হয়ে ঢোকে। আমি আজ অবধি ভারতবর্ষে অন টেবিল শেভিং আমার ছাত্র জীবনে দু একবার করতে হয়েছে, জিডিএ পাওয়া যায়নি, আদারওয়াইজ আমি দেখিনি। ঠিক আছে, আচ্ছা এবার অপারেশন থিয়েটার, আবার হ্যান্ড ওয়াশ, ওয়াশ বানানটা ভুল হয়ে গেছে, সরি, আবার হ্যান্ড ওয়াশ। ওটির আগে সার্জনদের হাত ধুতে দেখেছিস? কে কে দেখেছিস? ওটির আগে সার্জিক্যাল হ্যান্ড ওয়াশ কে কে দেখেছিস? দেখেছিস? যারা দেখিস একদিন ওটিতে গিয়ে দেখিস হাউ দে ওয়াশ দেয়ার হ্যান্ডস। প্রপার স্কিন ক্লিনিং অ্যান্ড ড্রেপিং, staff movement in and out of operation theater must be kept to a minimum. একটু আগেই বলেছি ইনক্রিজড অপারেশন থিয়েটার ট্রাফিক, কাজে এটা কমাতে হবে। এইটা হচ্ছে খুব সোজা জিনিস, এই প্রিভেনশনটা। তুই যদি কষ্ট করে রিস্ক ফ্যাক্টরটা পড়ে ফেলতে পারিস, এবার চিন্তা কর তার অ্যান্সার এখানে। এম আই ক্লিয়ার? তুই রিস্ক ফ্যাক্টরটা পড়েছিস, কি কি পড়েছিস? হাইপার টেনশন, তো হাইপার টেনশনটা কারেক্ট করো, অ্যানিমিয়া, অ্যানিমিয়াটা কারেক্ট করো। কষ্ট করে দুটো মুখস্থ করার কোনো দরকার নেই। ক্লিয়ার? রিস্ক ফ্যাক্টরে বলেছি ইনঅ্যাডিকুয়েট ডিসইনফেকশন, ইনঅ্যাডিকুয়েট স্টেরিলাইজেশন, তার প্রপার স্টেরিলাইজেশন করো। রেগুলার সার্ভেইলেন্স অফ স্টেরিলাইজেশন অ্যান্ড ডিসইনফেকশন, that is important. Next is laminar airflow. What is this? Operation theater এ laminar airflow, অপারেশন থিয়েটারে গোটা এয়ার ভলিউমটাকে ঘন্টায় ৩-৪ বার ও রিপ্লেস করবে। কলোনি কাউন্টটাকে মিনিমাম রাখবে, 15 থেকে 20 পার কিউবিক মিটারের মধ্যে নিয়ে আসবে। Gentle tissue handling of the by the surgeon is very important. এই চল কাট, এই জোরে টান, কি হবে? মাইক্রোট্রমা হবে, মাইক্রোট্রমা হবে। মাইক্রোট্রমা হলে ওখানে ইন্ট্রামাস্কুলার হেমাটোমা হবে। আর কি বলেছি একটু আগে, ব্লাড ইজ আ ভেরি গুড কালচার মিডিয়া। ব্যাকটেরিয়া ব্লাড খেতে ভালোবাসে। সোজা হিসেব, আমার মতো পেটুক লোক বিরিয়ানির দোকান দেখলেই ভিড় করবে, তাই না? ওটা ব্লাডটা হচ্ছে ওদের বিরিয়ানি, দে আর গোয়িং দেয়ার টু হ্যাভ দ্যাট ফুড। কাজেই জেন্টল হিমাটোমা ফরমেশন ঠেকাও, প্রপার হিমোস্টাসিস করো, কোথাও ব্লাড অ্যাকিউমুলেট করতে দিও না, ক্লিন দ্য উন্ড। দ্যাট ইজ কারেক্ট সার্জিক্যাল ট্রেনিং। অ্যাভয়েড পোস্ট অফ হাইপোথার্মিয়া, আগেই বলেছি হাইপোথার্মিয়া ইজ এ রিস্ক ফ্যাক্টর। সাপ্লিমেন্টাল অক্সিজেন ডিউরিং রিকভারি, ঠিক আছে? পার্টিকুলারলি অ্যানারোবসের ক্ষেত্রে এটা খুব ভালো। আমি যদি টিস্যু অক্সিজেন কন্টেন্টটা বেশি করে দিতে পারি, অ্যানারোবস তো গ্রোই করবে না, তাই না? এরপর হচ্ছে প্রোফাইল্যাকটিক অ্যান্টিবায়োটিক্স, ওটা নিয়ে পরে আবার আসছি। নাও কামস, তাহলে আমার সার্জারি অ্যাকুয়ার্ড ইনফেকশন হলো, আমি 3টে পার্টে প্রথমেই ভাগ করেছিলাম। ইনফেকশনস দ্যাট অ্যারাইজেস আউট অফ সার্জারি, সেই পার্টটা মোটামুটি ডিসকাস করলাম। কারোর কিছু বলার থাকলে, ইফ এনিবডি হ্যাভিং এনি প্রবলেম প্লিজ স্পিক আউট। যদি অসুবিধা হয় পরে, যদি পরে কিছু অসুবিধা হয় আমার কাছে যখন তখন কন্ট্যাক্ট করতে পারিস। ওকে, আই উইল গিভ অল অফ ইউ মাই ফোন নাম্বার, ঠিক আছে? বা হোয়াটসঅ্যাপ করে প্রবলেম জানতে চাইতে পারিস, নো প্রবলেম। হ্যাঁ, আমি বিজি থাকলে দেখবো না, না থাকলে আমি অফকোর্স রিপ্লাই করবো। আর when asking questions, just introduce yourself by WhatsApp. Who are you? From where? Okay? Now comes the next thing. Infectious diseases that require surgery. এটা নিয়ে বইয়ের পর বই লেখা আছে, এটাকে কি করে লেকচারে আনা যায় জানি না। Commonest infectious disease that need a surgery is an abscess. It can be perianal abscess, it can be any skin and subcutaneous abscess, it can be appendicular abscess, it can be subphrenic abscess, it can be empyema-thoracis, that is abscess within the pleural space, it can be infection within the peritoneal, abscess in the peritoneal space. I have already talked about subphrenic, it can be appendicular abscess, it can be pelvic abscess. And all these need drainage of the pus. Abar going back there. Wherever there is pus, you have to take it out. No if, no but must. Pus, take it out. Either by open surgery or laparoscopic surgery or thoracoscopic surgery or image guided drainage. So these are this. Next is another type of infections which need surgery. For example, tuberculosis. Tuberculosis of the gut can give rise to strictures within the gut. Am I clear? What is stricture? That is narrowing of a part. Whenever there is significant narrowing, it can give rise to intestinal obstruction. A drain is going there and there is obstruction. You have to remove that obstruction, otherwise the room will be flooded. That needs surgical intervention. This comes into this group. Okay? Human papillomavirus infection can give rise to genital warts, particularly in women. You have to remove them surgically. These are the example of infections that require surgery as a treatment. Am I clear? Cholangitis, that is infection within the bile duct. We are not doing open surgery, is obsolete for cholangitis nowadays. What we do? We do a ERCP and insert a stent into the bile duct and the pus drains out into the gut. Okay? Next is healthcare associated infections. Healthcare associated infections are a rarity, are faced by surgeons, but do not need surgical treatment. For example, a patient with peptic perforation admitted in a ward, or a patient with carcinoma stomach is admitted. I have done a gastrectomy, the patient is going to stay there for 6 or 8 days. He develops an infection due to IV cannula, can develop an infection due to the urinary catheter, can develop an infection due to the drain, ascending infection into the gut. These are healthcare associated infections. They seldom need surgery. But the surgeons, because the patient is admitted under their care, often has to treat them. Clear? These are the examples. So this is in a nutshell surgical infections. Now let me come to the topic where I have very little to write, only to say. What is that? Role of antibiotics. Can anyone define antibiotics? Can anyone define antibiotics? Tell what is an antibiotic? অর্গানিজম থেকে সিনথেসিস হয়ে অর্গানিজমকে মারবে, এটাই ছিল। এখন তো সিনথেটিক অ্যান্টিবায়োটিকে পৃথিবী ভরে গেছে, এটাও মাথায় রাখতে হবে। যাই হোক, এবার অ্যান্টিবায়োটিকের প্রচুর ক্লাসিফিকেশন পড়েছিস, পেনিসিলিনস, এনসেফালোস্পোরিনস, সালফোনামাইডস। হ্যাঁ, এখনো হয়নি, আচ্ছা হবে। তারপর দেখবি কুইনোলোনস, তারপর দেখবি ম্যাক্রোলাইডস, তারপর দেখবি কি বলে স্ট্রেপ্টোমাইসিন গ্রুপ অ্যামাইনোগ্লাইকোসাইডস। ঠিক আছে? What these antibiotics provide us. At the turn of this century, around the year 2000, যখন তোদের অনেকেই জন্মাসনি, আমি তখন সবে MBBS পাস করে ইয়াং ডক্টর, তখন at the around 2000, তোরা তখনও জন্মাসনি বেশিরভাগই, তো অনেকেই জন্মায়নি, আর আমি তখন যা সদ্য পাস করা ইয়াং ডাক্তার, আমি 98-এ পাস করেছি। তখন নিউ ইয়র্ক টাইমস একটা সার্ভে করেছিল, হোয়াট ইজ দ্য গ্রেটেস্ট সায়েন্টিফিক ডিসকভারি অফ দ্য 20th century? হ্যাঁ বলছি, লেট মি ফিনিশ। নিউ ইয়র্ক টাইমস সার্ভেটা করেছে। সার্ভেতে ওরা যেটা পেয়েছিল অ্যান্সারটা অবিশ্বাস্য। যাদের বয়স তখন ছিল 50, মানে যাদের জন্ম ধর 1950s ঘরে, তারা বলেছে ল্যান্ডিং অন দ্য মুন ইজ দ্য গ্রেটেস্ট সায়েন্টিফিক ডিসকভারি, বিকজ 1969-এ মানুষ চাঁদে গেছে, 1950 সালে তারা জন্মেছে, তারা যখন টিনেজার, তাদের কাছে দ্যাট ওয়াজ দ্য গ্রেটেস্ট অ্যাচিভমেন্ট। যেটা নীল আর্মস্ট্রং বলেছিলেন, এ স্মল লিপ ফর হিউম্যান, ফর এ ম্যান, এ জায়ান্ট লিপ ফর ম্যানকাইন্ড। চাঁদে নেমে নীল আর্মস্ট্রং বলেছিলেন। যাই হোক, এটা আলাদা। কিন্তু যাদের বয়স 85 প্লাস তারা বলেছিল অ্যান্টিবায়োটিক্স। কেন? বিকজ দোজ ফেলোজ হ্যাভ সিন এ ওয়ার্ল্ড উইদাউট অ্যান্টিবায়োটিক্স। তারা দেখেছে ইনফেকশন হলে কিভাবে গ্রামকে গ্রাম ছারখার হয়ে যেত। শরৎচন্দ্র বদভ্যাস আছে? উপন্যাস পড়ার বদভ্যাস আছে কারুর? শরৎচন্দ্র যদি পড়িস দেখবি পল্লী সমাজে গ্রামকে গ্রাম কলেরায় উৎখাত হয়ে যাচ্ছে। That was the era before antibiotics. This is the importance of antibiotics. The problem is indiscriminate use. So every patient should be given an antibiotic. Is it so? No. Ideally not. Ideally every patient should not be given antibiotics. That is for Western books. It's a fact. Because they maintain their sterility in a much better way than we ever do. There is no harm in accepting that. So I have never seen or operated on any patient without a single dose of antibiotic. We give. Now what antibiotic should be given? When it should be given? For what duration it should be given? And for what purpose it should be given? We can classify this antibiotic pre or perioperative antibiotic therapy into two groups. One is prophylactic, that is preventive, and the other is therapeutic, that is to treat. And when it should be given? It should be given at the best 30 minutes to 1 hour prior to surgery, so that at the time of skin infection, the blood concentration of that drug is at its highest. Am I clear? Next is what antibiotic? It depends on the surgery. আমি একটু আগেই বলছিলাম, আমি যখন গাট কাটছি তখন গ্রাম নেগেটিভস আর অ্যানারোবস এর কথা মাথায় রাখতে হবে। So I have to think about metronidazole. I have to think about aminoglycosides. আবার আমি যখন হার্নিয়া করছি বা একটা সিএ ব্রেস্ট করছি বা ব্রেস্ট লাম্প করছি বা থাইরয়েড করছি, এখানে গ্রাম পজিটিভস এর কথা বেশি মাথায় রাখতে হবে। কিন্তু এখনকার দিনে মেজরিটি অ্যান্টিবায়োটিক্স ওয়ার্ক এগেইনস্ট বোথ গ্রাম পজিটিভ এন্ড গ্রাম নেগেটিভ, জাস্ট লাইক দ্য cephalosporins or the carbapenems like imipenem, meropenems, the penicillins like piperacillin, ticarcillin. So these should be prescribed accordingly. In Western world, what happens? There the surgeon or the physician has no role in selecting the antibiotic. In their country, it is the microbiologist who determines the antibiotic protocol of a given institution. These strict protocols are not maintained here. Because in our country, we all treat our patients according to our whims. Unfortunately, it is true. Because there are no standard guidelines. If you go to UK, you have to follow NICE guidelines, National Institute of Clinical Excellence guidelines. Those guidelines are there. If you deviate from there, you are gone. Your registration will be gone. And if there is any complaint against you, and if you have deviated from that protocols, you are gone. Fortunately for us and unfortunately for the patient, such protocols do not exist in our country. Second, there are many operation theaters which are simply not good enough. Even in certain medical colleges, okay? Even in certain medical colleges. তোদের ব্যাচ না তোদের পরের ব্যাচ? ঘুম থেকে উঠতে দেরি হয়েছে, no problem. Too early for next day. In mind, we should plan. We usually almost always start with a broad spectrum. Now, do we have to escalate? For example, I am operating on a hernia. So standard hernia is a clean wound, as I have already told you. So one dose of, say, a broad spectral single dose of ceftriaxone is often sufficient. But the problem is the hernia was containing gut. And during the operation, I inadvertently or accidentally, I opened up the gut. And there is some spillage. So a clean wound becomes a contaminated wound. Now I have to escalate the antibiotic. Am I clear? From ceftriaxone, say, for example, I am shifting to piperacillin tazobacter or something like that. This is the question of escalation. Or for example, I am dealing with a patient of carcinoma rectum and I am planning an abdominoperineal resection. That means I am opening the rectum. What is the number of bacteria in a stool? 10 to the power 6 per gram. In stool. Human stool at 10 to the power 6 bacteria per gram of stool. Am I clear? So can you count? Can anyone count? And you open that rectum. That means you have to start with a very wide spectrum. Now you end up the operation with lesser spillage in a clean way with proper pre or boil preparation. Then de-escalate, fine. Am I clear? This should be the basis of rational antibiotic treatment. And yes, one very important point. You must be aware of the prevailing and bacterial trends in your locality. In your locality. For example, that guy is from Rajasthan. I knew him from last week. He is from Rajasthan. In his state, certain bacteria may be prevalent, which may not be prevalent in, say, some guy who is in Shiliguri. It is quite happened. The climate is different. Everything is different. Even the disease patterns. Gallstones is very less common in southern India than northern India. Okay. So with this, I conclude today's topic.
Amongst those, already I explained one thing. Probably you have seen, but actually in your anatomy class, classifications of the head injury, already I explained these things. It is extracranial, skull, and then intracranial injuries. And classifications of the intracranial injuries is again as per the anatomical classifications. Anatomical classifications, already I told you these things. The brain is covered by meninges. That there are 3 layers of meninges covering the brain. And so naturally the brain injury and hemorrhage all actually happens in the layers. So naturally how it happens and how it actually occurs, particularly during some incidents, particularly what you know these things, road traffic injury is the commonest actually incident where the maximum head injury occurs. Otherwise, other than these things, assault and other things, but road traffic injury is very, very common incident which causes the head injury, and maximum fatal head injury occurs also in the road traffic injury. So naturally here, one thing you can see these things base of the skull, because again the same things, probably you see better here. I thought these things that was the small lecture hall. I could show you these things actually, how the anatomical peculiarity of the brain. You know all these things, because here, just can you remember these things? The lower half of the skull, particularly to understand the head injury, this particular thing is important, but the vault is not so important, because actually there is no anatomical peculiarity there in the vaults. It is very smooth. Only thing is these things, thickness of the skulls, where actually the fractures and resistance actually what can offer, that depends upon the thickness. But here actually things, there are so many ridges. Already you have seen these things here, because actually it is flat, it is 3-dimensional, you can see these things. Here the first thing is base of the skulls. Here the lot of ridges. Here one ridges is first things actually here. These things orbital plate, first thing orbital plate, and is anatomical. Anterior fossa, here anterior fossa has the peculiarity. This actually things here, one projected portion, probably these things is ethmoid bone. It's very, very important. Inside the brain, skull, there is one very sharp pointed projections, that is ethmoid bones. And then actually the plate, that is the things actually what is the plate. This actually plate, this actually cribriform plate, it is very, very thin. Frequently fractures occurs. Blood actually gravitates down to the nose, which actually can be expressed from the outside, but actually inside you cannot see these things. But here, by the way, you can nasal bleeding. But head injury, nasal bleeding. Why nasal bleeding occurs in the head injury? And what kind of injury actually causes the nasal bleeding? It is only expressions. Though it is nasal bleeding, nothing in the nose. It is actually in the brains, in the intracranial. So that is the here actually that peculiarity is there actually these things. It actually frequently fractures and the blood gravitates actually from inside the skull outside through nose. And nose nasal bleeding is the expressions of the head injury. Probably you have noticed, I do not noticing how many cases actually attended. And even the relatives case on other cases also street injury, there actually you can notice this thing, the nose, ear and nose bleeding is very common, and that is also expressions of the head injury. And next actually these things, this point particularly this here you see the orbital is very sharp, very sharp and projected. That is the main important point in the inside of the skulls, very sharp projected. So naturally this sharp and projected, that causes the serious brain injury in case of the particularly acceleration deceleration injury. Our students are actually spread out. I do not know why that the front seats are open, the thing, but you are spread out. Why these things actually? I do not know your intention. So next thing is this, the mid-cranial fossa. That is actually the not very spacious, but peculiarly there are so many things also there actually occurs. The first actually here actually pituitary fossa, here there are actually projected. The maximum injury here during the fractures actually causes the injury to the pituitary fossa and the pituitary. Actually there are so many complications because of that things. And another is the posterior fossa. This posterior fossa is capacious, is the largest of all. It is also very smooth and it actually holds the particularly occipital lobe. So naturally this anatomical peculiarity of the base of the skull is very important. When I explain actually the brain, the different kinds of brains injury, then you understand these things why this anatomical projections, anatomical peculiarity of the skulls is so important to know or to understand. So thing is this, now next thing actually if I go these things, the base of the fracture, that I told these things, the as you say these things, black eye, all these things, black eye also is these things actually inside the skull fractures also expressed as a black eye. Though there is no injury to the eyes, but still the intracranial injury in the fractures that gravitates through the fractures and expressed as the black eye or spectacle eye. So again I am coming to that same points again, the how the anatomical structures. I already told you these things, the brain is covered by meninges. Brain is loosely fitted inside the skull. Brain is movable. Brain is covered by the meninges. Meninges has got 3 layers. And so all the layers, it's not that actually things is the same uniform. Some, though definitely they are fibrous, but their thickness and their structures is a little different. So naturally, if you know these things, how the meninges layers actually the covering the brain, already I told these things, either you say outside inwards or inside outwards. So very easy to remember is this way the dap or pad. Here I also told you this thing, I told this thing, that means the bone, bone means skull, skull bone. Then underlying these things dura mater, then comes arachnoid mater, then comes pia mater, then actually pia mater, the brain. So naturally these 3 meningeal layers, if these things early outside inwards, these things skull, then actually dura mater, then arachnoid mater, then pia mater, these 3 layers of meninges covering the brain. Again brain is movable, that means there is a gap beside the meninges also to the skull. But here this the bone dap or brain actually this is how you remember these things, because it is very important. Remember, because in intracranial hemorrhage classification, so naturally the dispositions of the meninges is very important, very important. So this is the way, easier way to know all these things. There is no space, mind the things. There is no space. This is an important point. Actually, what is actually highlighted in these PowerPoint projections. These things. There is no space between bone and dura or dura and arachnoid mater. I told you these things. তাহলে meninges লেয়ার আছে, কিন্তু there is no space. That means they are intimately actually adherent. But I again say, I stress on this point, no actual space but potential space. That means they are separable. They are soft tissue. This one after the, they can be. That means if you stretches, if this thing, so naturally the hematoma or blood or space occupying lesions or some things that can actually separate two layers and actually lies in between the two layers. And then actually you can see the spaces, that is dural space, subdural space. So, and there is actual space between, but I told this thing, actual space between two layers, arachnoid meter and pyometer. Ki thake? Subarachnoid spaces. That is the very important thing actually where the brain glides, that is CASF. Very small amount of the fluid CASF, but that is very important and that protects brain. Brain is movable. I told you this thing. Brain is movable, but that CASF is very important. That actually in the subarachnoid space, and then that thing is pia and brain. It is inseparable. Pia cannot be no humming. Not things actually the pia. That's why, so there is, the pia cannot be separated from the brain. So all these blood vessels, pia is very important, cannot be separated. That's why it is very important to know these things. Then again you see these things. So how is these things? Skull. Then dura. So then dura above skull and below arachnoid meter. So above these things, dura, above dura or epidural space, it is between the skull and dura. Then between the dura and the arachnoid is subdural. Again, there not actually there is no space, but it is potential space, can be separated, because actually when the blood accumulates, that actually where it accumulates, where it can be accumulated, actually it can be explained through this anatomical configurations, all these things. And that actually another thing is meningeal artery, actually is very these things above these things, below things, very important actually when we explain all these things. But actually I am going to explain these things, what is extradural hemorrhage. In the classifications I told these things, hemorrhage occurs in all layers. It can be accumulated in any meningeal layers. So first of this, I told you these things, it is in classification, epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and subpal, that is not, that a classification is very important. Then often it comes and it's very important. So here it is the things, see in epidural, actually epidural, epi means above, or it is known also extradural, epidural or extradural. It is the space between the skull and dura mater, though there is normally thing. This is important because this dura mater, the child and old matters is almost adhered to the skull. It cannot be separated. In the child, because of these things, the space dura mater is all the skull sutures, all these things actually continuous with the outside. So it is actually very difficult to separate. And the old age, adhesions. So if you attain, I do not know that is actually whether there is any space. During the anatomical dissections, did you do those things? The head dissections? I do not know. These days you do or not. So you can see this because actually anatomical, all the bodies anatomicals are generally donated. And they are actually matured age, this is old age. Here you can this thing, you cannot separate the dura from the skull. It's very, very intimately adherent. It's very, because of these adhesions. And that's why epidural hemorrhage does not occur in extremes of the ages. কারণ dura থেকে সেপারেট করা যায় না, স্কালকে সেপারেট করা যায় না। The child খুব বাচ্চা ছোট ছেলেদের ন্যাচুরালি সেখানে because of the skull sutures they are continuous, সেখানে করা যায় না, blood accumulate, that cannot be accumulated there. And old age, because it is adherent, that's why the epidural hemorrhage is actually very, very uncommon in extremes of ages. That is actually very, very important actually word. Often I ask actually that higher examination, gold medal examination, sometimes maybe oral or behavioral. That actually information is very, very important. কেন বাচ্চাদের, কেন young adultদের only বেশি হয়? particularly unfortunately young adult suffers from the external hemorrhage and often they die. And that is also the sports injury during the game, because you see the football games, you think there is a head clashing. Some persons actually comes actually for the balls, actually both persons that collides, and that head injury, that head thumping is very dangerous. It causes inside the brain injury, and that offends injury, because young adults, particularly in the 25 years to 35 years is very vital. And childer কেন হয় না তার একটাই কারণ, because of these things sutures, the durameter is very intimate. আর একটা base of the skulls আমি পরে আসছি, epidural hemorrhage is not found. কেন বলো তো? The base of the skulls has too many sutures, too many bones actually unite shears, and so also durameters intimately at the sutures. So there is no space. It is very difficult to space. And again, if any fractures occur, the blood gravitates down. তাহলে বাইরে চলে আসে. Even some that accumulates here. And as I told you these things, through the nose bleeding, and here in the middle, particularly this, actually if that fractures inside the skin, actually the blood comes out through the ear. তাহলে কি হয়? এটা anterior cranial fossa চলে, nose, mid cranial fossa, particularly sphenotemporal junctions here, naturally that goes to the ear. So ear and particularly nose bleeding is very significant in RTI, that signifies that there is head injury. The doctor must be aware of this fact, because that is the external expression. Don't wait for the CT scan to the MRI scan, X-ray and other things. Attend immediately, taking the patient as a serious head injury patient. And that is very important for the doctors to know. Otherwise, they will be charged of this negligence, serious negligence, which caused death. So naturally, that is very important. So some informations. Again, only things point 1. Already I told these things. Epidural or extradural means what? Epi, above the dura. So epidural hemorrhage, and that is also the extradural hemorrhage. That is outside the dura, or that is again in these things that occurs. That blood, I explained these things. So naturally what happens? This space between the bone and dura, skull and dura, epidural space is there. Blood at the bone and the dura. Almost always due to the trauma, generally acute type, এই hematoma সব সময় হয় trauma জন্য. There are so many types that is very important to explain why the person died, even in the hemorrhages, where actually hemorrhage and why the persons died. That is very important to explain. So this thing is there. The almost always due to the trauma, generally acute type. আবারও বলেছি সেই acute টাইপটা কিরকম trauma, সে মাথায় head thumping হতে পারে, cricket ball, যে জন্য তোমরা, if you notice this thing, probably most of the things actually I do not know how many like the footballs or other soccer, but actually these days in India there are many likes this cricket. So cricket, you see the head mate, if you notice these things, there is also one guard there. That is that ear is not to protect the temporal region. Head injury is very common here, and these things particularly side-on stands. Normally cricketer, all these things better actually side-on stands. The cricket balls, you think that hit the side of the head, and that is very dangerous, very sensitive. That is a temporal region. So epidural hemorrhage commonest space is temporal regions, just on the ear, temporal region. So that's why the guard should be there. Otherwise, that causes epidural hemorrhage, acute type, and person often dies and become unconscious. That is a different issue, but often dies. The most commonly occurs at temporoparietal region. Say information ta kintu keu bhulbe na whole life. If it happens to the, once you pass here, from here, either you will have to be employed or you will start practice. But the thing is, these things, everybody has to attend the emergency patient. No doctor can refuse emergency patient. You can choose patient. Doctor can choose patient. আমি একে দেখবো না, doctor can choose. But in case of emergency, you have no choice. You have no choice. You have to attend. Unless you attend, that is a criminal offense. You will be immediately arrested. You may be imprisoned. So naturally, be careful, all the doctors who are going to, because you aspire to be doctor, you join here to be doctor. Excellent. Very small. So another thing is, probably you know the coup. Coup কি টার্মটা বলো তো? খুব শুনেছো, সবাই শুনেছো। What is coup? Coup or coup? Actually, military coup. The throne, he is displaced from the throne by the military coup. Coup. Coup means sudden revolt. তাই তো? মিলিটারি হয়। এটা তো শুনেইছো, নেবারিং কান্ট্রিজগুলোতে এটা তো একটা হলো, আজকে ডেমোক্রেটিকলি ইলেক্টেড কোনো প্রেসিডেন্ট হলো, সে ডিথ্রোনড or the displaced by coup. That coup is actually, these things actually direct thrust open these things. So here also our thinking, coup injury and contra coup injury. Two types of injury. We shall explain. Say head injury, these two term is very important. Coup and contra coup. Coup means COUP. Coup injury. Coup injury means direct trauma. Contra coup, এদিকে মারলাম আমি, চোটটা এদিকে লাগলো, কিন্তু ইনজুরিটা হলো এদিকে। ইনজুরিটা হলো এদিকে, ওপেন ইউ ডু নট নো অ্যান্ড উইল হ্যাভ টু কাম এক্সপ্লেইন ইট, যে কি করে হয় এটা। আমার এদিকে কোনো চোটই লাগেনি, কিন্তু আমার লেগেছে এই দিকটায়, মেরেছে এই দিকটায়, কিন্তু ব্লিডিংটা হয়েছে অপোজিট সাইড। That is known as contra coup injury. That mechanism of contra coup injury I shall explain actually through the thing. Mechanism of contra coup injury. Never occur opposite side of the impact. কিন্তু external hemorrhage-টা অলওয়েজ কু ইঞ্জুরি, মানে যেদিকে মারবে সেদিকেই হবে, অপোজিট সাইডে ইট নেভার হ্যাপেন্স। এই দুটো ইনফরমেশন বলে নিই তোমাদের। এনিওয়ে, ট্রাই টু লার্ন দিস থিং। তাহলে ব্লিডিং কি কি আছে ব্রেনের মধ্যে? ভেসেলস, আর্টারি, ভেইনস, সাইনাস and all the capillaries, venous capillaries, arteriovenous capillaries. The bleeding actually can occur from this artery, blood, big arteries, small arteries, veins. But here, because actually the severity of the head injury depends upon these things, origin of source of the bleeding. Because actually যদি হয় arterial bleeding হলে কি হয়? Arterial bleeding, how you identify arterial bleeding? আমি একটা চোট মারলাম, spots. Arterial bleeding spots actually that happens because actually there was a injury, the cutthroat injury actually that happened in the Calcutta is Belaghatta. We had to inspect, to visit the site, because that was I complained he was killed or actually brought and killed elsewhere. So naturally that requires the spot to be visited. On visiting the spots, what we found? These things actually, I told these things because post-mortem examination it was found these things. The carotid artery was cut. Carotid artery, but the cutthroat injury, not that the carotid artery is often cut. It may not be cut because it is deep-seated. So if carotid artery is cut, so what will be the finding in the spot? Jodi ekhane mare, if actually the person is killed here or the elsewhere killed and disposed here, that happens. That is very important things to be found out. Ki hobe? Because carotid artery was cut, as he said, there is a severe, মানে ব্লাড এখান থেকে ছাদে চলে যায়, এত স্প্রেইং অফ দ্য ব্লাড অল অ্যারাউন্ড, ইভেন দ্যাট গোজ দ্য হাইট অফ দ্য রুফ 8 feet, even this thing that can reach, it depends upon the patient. So naturally, if he was killed and he was cutthroat occurred there, we could notice the spread of the blood, but nothing found. So it was evident he was killed elsewhere and actually the disposed here. So naturally, so it was a frank case of the murder. So naturally, because it is from the things actually once elsewhere is killed and the body is found, others actually somebody has to be carried there with the intention, and it was homicide. So this is how the murder rule is established. How the murder is established from these findings. So anatomical peculiarity, the bleeding, and findings on the body in the spot. So all these things actually, if you analyze all of these things, and there also it can be said these things actually the how the person, this because actually injury, if there is fight or there is not fight, it is not possible to do the cutthroat injury with a very able persons without any resistance. So naturally there should be some other findings. So this sort of investigations, all these things depends upon with your knowledge of medicine, otherwise you cannot explain. Extradural hemorrhage not found at the base of the skull. আমি বলেছিলাম base of the skull এ extradural hemorrhage হয় না, কেন হয় না সেই anatomical knowledgeটা কিন্তু থাকতে হবে. It can only be explained by the doctor. That's why it's a foreign, though legal medicine, but it is medicine because it's required to be explained by the doctors only. Otherwise, without this medical knowledge, it cannot be explained. একটা জিনিস দেখো তাহলে এক্সট্রাডুরাল হেমারেজটা কখন হয় বাই দ্য ডাইরেক্ট ট্রমা, সেটা কি করে বুঝবো? তাহলে মাইরের ডাইরেক্ট ট্রমা হলে কি হবে? ফার্স্ট মাথার উপর দিয়েই তো মারবে, তো ন্যাচারালি দ্যাট শুড বি এভিডেন্স ইন দ্য স্ক্যাল্প অলসো. তো এক্সটার্নাল এভিডেন্স অফ দ্য হেড ট্রমা ইজ স্ক্যাল্প সোয়েলিং, অ্যাব্রেশন, ল্যাসারেশন. একটা কিছু মারার দাগ তো পাবো, সেটা এইভাবেই পাওয়া যেতে পারে. সো ন্যাচারালি দিস থিংস ফ্রম দ্য এক্সামিনেশন. সো ট্রমা হ্যাপেন্স বিকজ এক্সট্রাডুরাল হেমারেজ হ্যাপেন্স অনলি বাই ট্রমা. কিন্তু ট্রমা হয়ে থাকে কোথায়, কোথায় মেরেছিল? সো ন্যাচারালি দ্যাট থিংস অ্যাকচুয়ালি অকার্স হিয়ার ইন দিস কেস. দ্য ক্লাসিক্যাল প্রেজেন্টেশন অফ দি প্রবাবলি আবার একটা কথা বলছি, দেখো ডিটোরিয়েশনস অফ দ্য কনসাসনেস মে অকার ওভার মিনিটস টু আওয়ার্স. ফার্স্ট থিং উইথ দ্য ট্রমা পার্সন কিন্তু আনকনসাস হয়ে যায়. এটা দেখা গেছে একটা ফুটবল গেমে, বিকজ অ্যাকচুয়ালি দ্য পিকুলারিটি অফ দ্য লুসিড ইন্টারভ্যাল বলে একটা কথা আছে. লুসিড ইন্টারভ্যাল নোট রাখো. Lucid interval is the period of consciousness or period of wellness between two unconscious unwells. Unconscious হয়ে যাবে, আবার দাঁড়িয়ে পড়বে, অলমোস্ট কমপ্লিটস. মাঝে মাঝে এমন হয় সে পুরো স্টেটমেন্টও দিচ্ছে যে কি হয়েছিল, বাট এগেন দিস থিংস অ্যাকচুয়ালি হাউ বলবো তার একটা পিকুলারিটি আছে এই জায়গাটাতে, হোমিসাইডগুলো যেটা হয়. তো কি হবে? তারপরে খেলার পরে এমন দেখা গেছে একটা ফুটবল খেলাতে যদি পড়ে গেছে, ফুটবল খেলতে খেলতে ইয়াং 12 years boy, actually these things 12 years 14 years like these things, actually he fell unconscious, but immediately actually just within a few seconds after this thing immediately he stood up and complete the game, but on completion of the game he again fell down and died. That is a very peculiar history of a এক্সট্রাডুরাল হেমারেজ. এই হিস্ট্রি থেকে কিন্তু বোঝা যায় যে কোথায় কি হয়েছে. দ্যাট ইজ কল্ড এ লিউসিড ইন্টারভ্যাল. ক্রিমিনালি অলসো ইট ইজ ভেরি ইম্পর্টেন্ট. কেন বলছি এটা হয়? এটা হেড ইঞ্জুরিটা গাড়ি অ্যাক্সিডেন্টে হয়, আরটিআইতে হয়, আবার অ্যাক্সিডেন্টেও হয়, হোমিসাইড, এটা ভেরি ইম্পর্টেন্ট. কিন্তু এক্সট্রাডুরাল হেমারেজ এটা হয় হচ্ছে যে রেট্রোগ্রেড অ্যামনেসিয়া. ওই যে আনকনসিয়াস হলো সে কিন্তু ঠিক তার পেছনটা কিন্তু ভুলে যায়, ওই সব বলে যাচ্ছে. সে কনসাস হয়ে যাওয়ার পরে এভরিথিং অ্যাকচুয়ালি হি নারেটেড এভরিথিং, হি নারেটেড এভরিথিং যে কি হয়েছিল এই ব্যাপার, তারপরে কি হয়েছিল, রেস্কিউয়ার্সের সঙ্গে কথা বলছে, কিন্তু হি কুড নট সে হাউ ইট হ্যাপেন্ড. এক্স্যাক্টলি বিফোর দ্যাট পয়েন্ট অ্যাকচুয়ালি হি ক্যানট এক্সপ্লেন. দ্যাট ইজ এ পিকুলিয়ার থিং অফ দিস থিংস. retrograde amnesia is forgetfulness, actually that happens. So extradural hemorrhage has so many medical peculiarity. It is very, very important in case of the criminal investigation. So here also these things, lucid interval is another thing. Though the 35% in cases occur, but it is characteristic of extradural hemorrhage. ভুলে যাবে না, it is characteristics of the extradural hemorrhage. আমি জানি না where you study, it is very taken from a very famous book. একটা ইমার্জেন্সিতে এক্সট্রাডুরাল হেমারেজ এসছে, এটা যেহেতু এখানে হসপিটাল হয়েছে, you may be actually, I do not know in near futures, you may be actually able to know these things actually on head injury patient. কারণ রাস্তার যদি অ্যাক্সিডেন্ট হয় তাকে তো সঙ্গে সঙ্গে হসপিটালেই নিয়ে আসবে, নিয়ার বাই হসপিটাল, অ্যান্ড ডক্টর হ্যাজ টু ট্রিট ইট. তাহলে কি করবে একটা পেশেন্ট, হেড ইঞ্জুরি পেশেন্ট, ইমিডিয়েটলি এবার আর মনে রাখবে যেন কি বলেছিলাম, আনকনসিয়াস হয়ে যায়. তাহলে পেশেন্ট মে বি আনকনসিয়াস, পেশেন্ট মে বি কনসিয়াস, বাট হোয়েদার ইট ইজ এ হেড ইঞ্জুরি, হোয়াট ইজ মোস্ট ইম্পর্টেন্ট, আর বলছি রোড ট্রাফিক ইঞ্জুরি, হেড ইঞ্জুরি, অ্যান্ড হোয়াট ইজ ইমিডিয়েটলি ক্যান বি ইমিডিয়েটলি ফেটাল, দ্যাট ইজ এক্সট্রাডুরাল. তাহলে এটা কিন্তু এমার্জেন্সিতে এক্সামিনেশন করেই জানতে হবে. ইট ইজ টেকেন ফ্রম এ ভেরি ফেমাস দ্য কেপি দাস সার্জারি. Probably I do not know whether you study these things. কিনেছো জানো, কে দাস, আমাদের সময় ছিল কে দাস, then actually it is edited by probably his son is Das. Whether you read this book, it's very, very fantastic book and unparalleled book. It was these things KP Das's surgeries, but particularly practical surgery. So naturally there from these things what happens to the pupil. দেখো ফার্স্ট লাগলো মাথার এদিকে চোটটা লাগলো আমার তো কিছু নেই ডক্টরস টর্চ অনলি থিংস don't wait for the CT, MRI, X-ray, other things. Clinical examinations can actually detect the so fatal injury. So naturally just look at the pupils. So naturally by the time patient may be unconscious, may be conscious, because patient may be in the lucid interval, may be unconscious. But anyway, that may be unconscious means last unconsciousness. That means between this thing, that is terminal event. The patient may die within a very short time. So immediately you attend these things. Actually, it may not be able to these things, but you must diagnose these. তাহলে কি হবে ফার্স্ট দেখো এই পিপল তোমার হাতে তো টর্চটা আছে আর কিছু না থাক টর্চ একটা ডাক্তারের কাছে থাকবে টর্চ হ্যামার স্টেথো এই দুটো ইজ very, very fundamental instruments carried by all the doctors. And another thing is the finger. So naturally with these things, you must examine the patient and see. যে দিকটায় চোট এই দেখো একটা দিকে পিপল কিন্তু এই দেখো একটা জিনিস পিপল নর্মাল আর একটা দিল পিপল ডাইলেটেড তাহলে কি হয় পিপল নর্মাল কনস্ট্রিক্টেড ডাইলেটেড তাহলে এইখানে একটা জিনিস ফার্স্ট কথা হচ্ছে যে এদিকটা কিন্তু নর্মাল যদি হয়ে থাকে কনস্ট্রিক্টেড হয়ে গেছে তাহলে এইখানে আবার এই পিপল দেখো ডাইলেটেড নেক্সট অপোজিট সাইডে কনস্ট্রিক্টেড দেন বোথ সাইড ডাইলেটেড পিকুলিয়ার থিং দেখো ফার্স্ট থিং যদি ডাইলেটেড এই দিকটায় বিকজ অফ দিস থিংস ইপসিল্যাটারাল সাইড অফ দ্য ট্রমা মানে যেদিকে লেগেছে সেদিকের পিপলটা আগে কিন্তু কনস্ট্রিক্টেড হয়ে গেছে অপোজিট সাইড নর্মাল তারপরে কি হলো এই যেদিকটা কনস্ট্রিক্টেড হলো সেটা ডাইলেটেড হয়ে গেল অপোজিট সাইডটা হলো কনস্ট্রিক্টেড এটা না পড়লে বুঝতে পারবে না দিস থিং দেন বোথ সাইড ডাইলেটেড দিস ইজ দি থিংস টার্মিনাল ইভেন্ট পেশেন্ট কিন্তু মে ডাই উইথিন শর্ট টাইম এই স্টেজে যদি তুমি দেখতে পাও তাহলে বুঝবে যে পেশেন্ট কিন্তু অ্যাট দ্য টার্মিনাল ইমিডিয়েট অ্যাটেনশন ইজ এসেনশিয়াল আদারওয়াইজ ইউ মে actually lose the patient. So it is the doctor's duty to attend the emergency patient and try to save the life of the patients. I hope this is the goal of every doctor. These things actually I must save the life of a patient or person. So this is called this thing actually this thing Hutchinson's people. Hutchinson's people expressions, the clinical investigations, the how you can diagnose it. These days the many actually depends upon this investigation, but investigation takes time. But the action is very urgent. To save the life, action is very urgent and then depends upon your clinical knowledge. Simple things within torch and pain and other things you can diagnose so many very fatal cases. Here it is very important. In 60% of the cases there is dilated people on the affected side due to the ankle herniations এটা একটু পরে unless you read all these things because you are very short times focal neurological signs which are usually contralateral to the side of the scalp injury মানে এদিকে চোটটা লেগেছে অপোজিট সাইড প্যারালাইসিস সেন্সেশন কারণ অ্যাকচুয়ালি ব্রেনের ইউ নো দিস থিংস ব্রেনের অপোজিট সাইডে সব প্রসেস হয় তাই না একটা সাইডের সেন্সেশন আর একটা সাইড আছে হেমিপ্যারেসিস or the paresis if occurs that is contralateral means opposite side এ হবে opposite side paresis মানে opposite ট্রমাটা কিন্তু উল্টো দিকে লেগেছে this no actually is very important contralateral side and the hematoma is ipsilateral আবারও বলছি যদি কনস্ট্রিকশন হলো ওদিকেই কিন্তু হেমাটোমা ইপসিলাটারাল মানে সেই সাইডে ট্রমাটা তাহলে যেদিকে চোট সেদিকেই কিন্তু হেমাটোমাটা হয়েছে this way you can diagnosis or the simple bar hole or release আগের দিনে ছিল না এত সব কায়দাতে the bar hole on release operations can save the life of a person if the life is valuable because সবাই তো পেডেস্ট্রিয়ানস হয় না গাড়ি চালাতে চালাতেও এরকম অ্যাক্সিডেন্টস হয় that baby thing large hematoma produce severe midline shift এতটা আর তোমাদের ক্লিনিক্যাল নলেজ বলছি না বাট থিং ইজ দিস থিং এক্সপ্লেইন কেপি দাস ইউ রিড কেপি দাস ইউ মাস্ট রিড I do not know whether it is available or other thing, but there is actually, I hope still it is not actually substituted by any other book. It's very fantastic book. Hutchinson's Medicines and Kepidas's surgery. So fantastic books. 35 to 100 ml of collection of generally basic now, 8 blood. That is the things, that is the pressure of the brain, that may be better. Autopsy, এটা autopsy তে বুঝি কি করে? Blood is always clotted. That is these things, blood loose থাকে না, and because it is arterial blood, that is always the blood pressure is also very high. Usual cause of death, তাহলে প্রেসারে কি আছে? Usual কেন মরে কেন? Because brain pressure, respiratory failure. Respiratory failure. So this is the knowledge, medical knowledge using what you see when you open the skull. So it cannot be seen from outside. Only thing is this thing, there may be a small trauma. Again, because of this hair, you cannot actually see any injury on the scalp. But these things, consciousness, unconsciousness, constriction, dilatation of the pupil actually explains. And then, and if he dies, you'll have to know, you'll have to explain why the person died. But is it a doctor's fault or really the fault? Yes, doctors are often in problem because of these things. Because of the doctors are problem means they are actually charged of negligence. They did not attend. That happened in the case of the NRS Medical College. There are severe commotions, and so many doctors are also beaten, and there are so many damage to the hospital property by the very big mob. Because the persons died, attended hospitals in NRS Medical, and that these things released the, for instance, you know, probably I do not know how many of you know this in NRS Medical College scene. Yes, I am students of the NRS Medical College. So naturally that time, after the release, patient only come from this hospital emergency, and outside there is also tramline and other things. Without these things, patient fell on and died. And that patient was from the nearby locality. So big mob, unruly mob attacked all the doctors, emergency doctors, patient, Palestinian, so many things. And the quality of the mob you can understand, particularly those who are from that locality. So naturally that happens. So here doctors should be charged of negligence. It was a case of road traffic. Why the doctors did not understand that would happen? So immediate actions of the doctors is admit the patients for observations at least for 36 hours. That is the duty of a doctor. So doctor must know their duty in case of the emergency patients, unless otherwise, yes, they may be immediately attacked by the mob, but anything lawful actions will be taken against them. Serious medical negligence, and that may be a very serious. So naturally that is the things. How it appears, actually do not have that sample here, but here is things. Here it is just, it is a vault of the skull is taken out. So vault of the skull is taken out. So naturally what is exposed this thing? যখনই মাথাটা খুলবো তখনই dura matter is exposed. এই যে দেখতে পাচ্ছি আমি just these things, dura matter is very thick, dura matter and glistening, and here this is the clotted blood, discoid clotted blood. আগেকার দিনে যখন সিটি ছিল না, এটাও ছিল না, তখন এক্সরেতেই বোঝা যেত যে এরা একটা শেপের একটা জিনিস, opacity, যেটা এক্সরেতেই বোঝা যেত। সেখানে কিন্তু আছে যে এখানে বাকি then all the signs and symptoms that actually explain. Here these things, it is arterial blood, clotted blood adherent to the dura mater. It is epidural, peculiar, it is a typical epidural hemorrhage. Often you see, if you happen to see these things, I do not know whether there will be case, actually you can notice. But here at least you see these things. This is my case, I have got so many photographs, so naturally that is a very interesting case also. So this is actually these things, with the plot, তার পরের লেটারই আছে, মজার ব্যাপার আমি বলেছিলাম একটা কথা, এই হেমারেজটা কন্ট্রাক্ট হয় না। দ্যাট মিনস যেখানে লাগবে সেখানেই হেমারেজ হবে, অপোজিট সাইডে হবে না। তাহলে এটা দুদিকে হলো কি করে? সো হিয়ার দ্য বাইল্যাটারাল হেমারেজ, তার মানে দুদিকেই চোট লেগেছে, দুদিকেই চোট লেগেছে। দ্যাট মিনস দ্য ট্রমা দ্যাট হ্যাপেন্স। কি করে হয়? একদিকটায় লাগলো, উল্টে ছিটকে গিয়ে, রোড ট্রাফিক এটা খুব হয়, মাথায় এদিকে লাগলো, ছিটকে গিয়ে পড়লো, আরেক দিকে লাগলো, মোটর বাইক অ্যাক্সিডেন্টসে দ্যাট হ্যাপেন ফ্রিকুয়েন্টলি আছে, ঠিক আরেক দিকে, তাহলে দুদিকে। So naturally, the direct trauma. If the EDH is bilateral, there must have been the bilateral trauma. মানে দুদিকেই চোট লেগেছে, দুদিকে মেরেছে বা দুদিকেই চোট লেগেছে, একদিকে লেগেছে আরেক। তাহলে এই যে জিনিসটা খুব কন্ট্রাক্টিভ ইনজুরি, আর্টেরিয়াল হেমারেজ, and that is a clotted blood. এটা খুললেই, হেড খুললেই, first thing what we think, most of the fatal cases, then other hemorrhages that can be noticed. Again, the next step of the dissection. I actually in our time actually we have this thing head neck part, and that was about the 3 months continuously head neck part. So naturally that dissection has to be very meticulous. Everything, the dispositions layer, all these things, how it will things, and neck structures. It is very important because actually that explains so many cases. এটা নোট করো, because you have ample scope, you can take all these things. Medical legal importance, আমি এতক্ষণ ধরে বললাম কেন এটা important, why these things. This medical legal importance, because in forensic medicine, medical legal importance is because doctors has to save themselves during their practice while attending patients. So they must not be negligent, that they must take care, be careful to avoid these possibilities. So what is these things? Patient with EDH may be discharged early. আমি বলেছিলাম সেই এনআরএস মেডিকেল কলেজের এই বিশাল মব যখন অ্যাটাক করে তখন কেউ বাঁচতে পারেনি। সো মেনি ডক্টরস ওয়ার অ্যাটাকড, হ্যাঁ, সব কিছু হয়েছিল। তো কেন ওই ডিসচার্জ আর্লি? বুঝতেই পারেনি। এখন পেশেন্ট ইন দ্য লুসিড ইন্টারভ্যাল আনকনসাস ছিল, আবার কনসাস হয়ে গেছে, টকিং থিং. But again, that talking may be like alcoholic. Again, another problem arises because of these things. That patient behaves like an alcoholic. That thing sometimes appears drunken and maybe refused admissions. এবার যদি হয়ে থাকে, মুখে যদি একটু গন্ধ আসে, তাহলে তো কথাই নেই। তখন that will determine যে মাল খেয়ে এসছে বেটা, যা, ব্যাস। But trauma with drunkenness, alcoholic smell, that confirms the doctors, confuses the doctors. So discharge, but what happens? The alcoholic patient recovers, but EDH patients cannot recover, dies. And that happens. Doctor will be in serious trouble. Doctors will be in severe trouble because that incoherent talks, little confused talks, and maybe some alcoholic males behave like alcoholic patients, but actually that is a head injury patient, and doctor refuses admission, doctor refuses attendance, doctor refuses observations. So naturally patient, if fatalities occur, doctors will be in serious trouble. If dies soon after discharge or refuse admissions, যে কথাটা আমি বারবার বলছি, actually in my experience I have seen many cases and investigated so many cases, and that actually happens. Really this thing. And again, there is another case. What happens? The same type of travel occurs in the RG or medical college, another road traffic accident. They taken him as a head injury patient and they send them for the MRI, CT, again these things, without examining patient, without any clinical lesion, and patient died, 25 years old. And but actually that attendance by the time actually 2 hours is already lost. So naturally যা হওয়ার তাই হবে, যা হওয়ার তাই, মব অ্যাটাক, ভাঙচুর, কেউ বাঁচবে না। তো তাই হয়েছে। অ্যাকচুয়ালি সেটা হয়েছিল কিন্তু স্প্লিনিক, আলটিমেটলি অটোপসি সেটা আরজি করেই হয়েছিল। তার আলটিমেটলি দ্যাট অকার্স স্প্লিনিক রাপচার। আরে রোড ট্রাফিক অ্যাক্সিডেন্ট কি সবসময় হেড ইঞ্জুরি হয় নাকি? আর হেড ইঞ্জুরি তুমি আইডেন্টিফাই করতে পারবে না একটা বসে এমার্জেন্সি তুমি ডক্টর? Absolutely. So naturally they are actually subjected to the mob attack. There was NRS যা প্রবলেম হয়েছিল আরজি করে তার থেকেও বিগার প্রবলেম হয়েছিল, হ্যাঁ, 2 দিন ধরে চলেছিল। তো ন্যাচুরালি 25 বছরের ছেলে, আমার ছেলে, তোমার ছেলে, যারই ছেলে হোক না কেন, কেউ ছাড়বে না, তাই না? If that thing actually happens, the splenic rupture and the person can be immediately saved. Splenic rupture, বাবা আল্ট্রাসাউন্ড করলেই তো বোঝা যায় যে স্প্লিনিক রাপচারটা হয়েছে। অপারেশন করে দিলেই তো, স্প্লেনেক্টমি করে দিলেই তো বেঁচে যায় পেশেন্টটা, ব্লাড দিলেই তো পেশেন্টটা বেঁচে যায়। তো what the callousness, it is a serious callousness on the part of the doctor and hospital. It cannot be actually the forgiving all these things. Today it's all because again head injury is so important, so often actually comes, it causes so many problems. So naturally, I giving is more emphasis on the head injury. So this part extradural, I told you these things, there are subdural hemorrhage and intracerebral hemorrhages. All of these things I shall explain again in the next classes. I shall continue on the head injury in the next class. Probably the time is also up. Thank you.
Okay, so these are the presenting features, presenting symptoms: fever, gum bleeding, fever pallor, gum bleeding, and lymphadenopathy. Peripheral blood smear. So what is your provisional diagnosis? Question number 1. How will you investigate in lab? That is number 2. 4. Prognostic factors. Lymphadenopathy and abnormal lymphocytes are there. If I say CLL, then how do you know it might be? Okay, 1 to 10 years. So age in favor of ALL. Okay, male সেটা female হতে পারে, no problem. Fever. So these are features of, what are these features which I have explained to you in the last class? Fever, pallor, gum bleeding are because of what? These are the, see, you should know the clinical features very well. Fever, pallor, gum bleeding are because of what? You don't know the clinical features, you will never be able to answer these questions. Yes, anybody, can I pick up anyone? Random, I'll call out a roll number and that person has to stand up and answer me. Should I? Yes or no? No, okay, fine, then you tell me. Fever, pallor and gum bleeding are because of what? Recall the clinical features which I taught you. Pancytopenia. Okay. No. You shouldn't be answering like that. Fever, pallor and gum bleeding are because of what? Bone marrow failure. Yes, exactly. The entire thing is called pancytopenia. The entire thing is pancytopenia. Anemia is because of what? The erythroid lineage is destroyed. Means normal RBC production is seized. Pallor, fever and pallor are because of that. Why gum bleeding? Sorry. Pallor is because of that. Because of anemia. Fever is because of what? Granulocytopenia. Means the WBC lineage is affected. Then gum bleeding is because of platelets. Platelets are destroyed. So there is abnormal proliferation of these blasts which replace the normal hematopoietic elements out of the bone marrow. That's why patient presents with fevers, with symptoms of fever because of neutropenia or granulocytopenia, that is the WBC, normal WBCs are affected. Then you get pallor because RBCs are affected, and then gum bleeding because platelets are destroyed. So that is a triad basically. So this is because of bone marrow failure. Then you get lymphadenopathy. Why lymphadenopathy? What does this prove? What does this mean? Lymphadenopathy is because of what? If this is because of bone marrow failure, why lymphadenopathy? Lymphadenopathy is because of what? So, because of organ infiltration. Not necessarily you will get a lymphadenopathy. What if the examiner sets a question where he asks about splenomegaly? He can ask about hepatomegaly, which is much lesser, but questions can be framed that way. Not always you'll get the classical symptoms. So you must think in terms of an organ infiltration. May not necessarily be classical presentation every time. Okay? So lymphadenopathy is because of organ infiltration. And peripheral blood smear shows abnormal fair number of abnormal lymphocytes. So your diagnosis is, what is the full form? Acute lymphoblastic, come forward. Acute lymphoblastic leukemia. Acute lymphoblastic leukemia. So take exam point of view theke ami porachi. I'm teaching you exactly from the exam point of view what you have to answer. So the first and foremost thing is age group. Age group 2 to 7 years, but 1 to 10 years. Remember, less than 1 year and more than 10 years. Within 1 to 10 age group has a good prognostic value. Less than 1 year and more than 10 years, it has adverse prognosis. So within 2 to 7 years, but 1 to 10 years, young age group would say within 1 to 10 years. Okay, that is the first thing. Males are more commonly affected than females. Remember, males are more commonly affected than females. Cell of origin. It can be precursor B cells. 75 to 80% of the cases, or 80 to 85% of the cases are precursor B cells. And 15 to 20%, or say 20%, 25%, it's not exactly 80 or 20, in and around that figure. So the other is precursor T cells. So cell of origin is precursor B cells or precursor T cells. Now, if you recall, মেলরা কেন বেশি হয় সায়েন্টিস্টদের জিজ্ঞেস করো বাবা আমি জানি না should ask the scientists. Okay, I don't know, I haven't done any investigation on this. You know, even I don't know, never thought about it. Okay, so coming to the clinical features. Clinical features I have explained to you in the last class, and the lab diagnosis. The reason why I told you the general considerations in the last class is because it will help you to understand the lab features easily, because the lab features are similar. There is nothing new that I'm going to teach you here. Okay, so fatigue, bone and joint pain, fever, weight loss, purpura. You know why this happened. I've explained you, nothing new to explain. Okay, then you get lymphadenopathy, splenomegaly, hepatomegaly, sternal tenderness, and mediastinal mass. So remember, bone pain, like sternal tenderness, and involvement of the bone is much more common with ALL than AML. Remember, so if someone don't give you, for example, what do you say? You don't get a history of organomegaly, but you get a history of, say, sternal tenderness, then features go in favor of ALL. It doesn't mean that it does not happen in AML. It's more common with ALL. Okay, so you know the organs which are affected. Spleen more than liver. First and foremost is lymph nodes, then comes spleen, then liver, then bones. So these are the organs which are involved. Other than that, which organs are involved? Examiner may ask you in viva. These are the common things. Yes, thymus, mediastinal mass, and if the patient presents with a mediastinal mass, which is more common with TALL, it has a worse prognosis. So what are the other organs affected? Central nervous system. This is a site of relapse. Remember, central nervous system is a site of relapse. So in treatment, when we do remission induction, immediately after remission induction, if the count is very high, then doctors do a CNS prophylaxis. Okay, next is eye, testis. In case of males, testis. That is one reason why, I can't say why males are more involved, but when you consider the sex as a prognostic factor, males are affected more than females, because if it happens in males, their prognostic index is lower than women because of this testicular relapse. It can relapse in the testis, then the GI tract and the kidneys. So out of this, remember at least the CNS and the testis, because CNS is one point where these cells, CNS is basically a site where the lymphoblastic leukemic cells, where CNS acts basically as a harbor or a sanctuary. Okay, and then another site where it can relapse is the testis. That's why males, when they are affected, their prognostic, the prognosis is adverse for males as compared to females. So classification, One is FAB, French, American, and British classification. FAB is not used now. To be very honest, I'll be very honest with you, even though I have to teach you FAB because at your level you need FAB, but FAB is not the one which is recommended. WHO is the one which is studied in details. But now the point is you cannot remember every classification of WHO. It's humanly not possible to remember. So you have to remember few of them. So one is FAB, French, American, and British classification. Number 2 is WHO, World Health Organization. Number 3 is immunological classification. Immunological classification is not exactly a classification, but it's rather subtyping the B lymphocytes, the BALL and TALL, and I'll be discussing the BALL over here because that is around 80%. So what are the classification? FAB, one is French, American, and British classification. If the examiner asks you, can you classify, at least tell the FAB classification and the WHO classification. So coming to the WHO classification, huge, you can't remember. And that too, this is a very old one, say 2008 one. So one is B, lymphoblastic leukemia, lymphoma, NOS, not otherwise specified. Then comes B, lymphoblastic leukemia, lymphoma with recurrent genetic abnormalities. And each and every genetic abnormalities has some kind of prognosis or the other. Some are in favor, some are favorable, while some are unfavorable. For example, the first one that you see, T922, Q34, Q11.2. That is BCR-ABL. Where have you studied BCR-ABL? Philadelphia chromosome. Very good. Philadelphia chromosome. BCR-ABL. Why? You know why it's called Philadelphia? Huh? Where is Philadelphia? Oh, no, it's very good. So, I mean, question ta kori shobaike. Jara oneke uttor dite paren. But good, you have answered it. Philadelphia. So, BCR-ABL has a bad prognosis. Then the next one, TEL-AML1. TEL-AML1, which is T1221, P13, Q22. That has a good prognosis. So this is the reason why WHO classification is important. FAB does not correlate with the clinical behavior of the tumor or the prognosis or the treatment that a doctor is going to offer. But you have to know something on FAB. WHO is the one which correlates with everything. Prognosis, the treatment that will be offered, clinical symptoms, etc., etc. So you can't remember all, but you have to remember a few. For example, the first one, T922, that is BCR-ABL fusion gene, when they form, it has a bad prognosis. Okay, patients with that genetic abnormality, which is identified by immunophenotyping, if the patient harbors that particular genetic abnormality, that particular fusion gene, he is categorized in a poor category. T1221, P1322, that is TEL-AML fusion gene. Again, that has a good prognosis. Okay, so this is basically the classification, and then last one is T lymphoblastic leukemia lymphoma. So this is basically the WHO classification. At least you know that there's a classification called WHO and there's a classification called FAB. Immunologic is not exactly a classification, but rather it's subtyping of a tumor. Then coming to the, I'll be explaining you the FAB classification later when I'll be talking about the morphology. There I have given the L1, L2, L3 morphology and all. So next one is immunological. Just in immunology, I have just subdivided the BALL, which is important. So don't look into the markers right now. Markers will be explained later. And these are the same markers which I have taught you in the last class. So BALL is again classified into pro-BALL, okay, which correlates with L1, L2 morphology. In FAB, common ALL, CALL, common ALL, because that has a CD10, which is also called common antigen. Okay, it has the best prognosis. Then comes pre-BALL and mature BALL. Pre-BALL and mature BALL, they have a poor prognosis. This is very important. You must know all these things. At least no need to study in details, in depth, but if you know these points, that's more than enough for lab diagnosis. Remember the BALL. BALL is immunologically classified into, or subclassified into rather, pro-BALL, common BALL, then BALL or mature BALL or pre-BALL, Sorry. And last one is mature BALL. So the first two has better prognosis as compared to the others. The last two, that is BALL and mature BALL, pre-BALL and mature BALL, they have poor prognostic. They belong to the poor prognostic category. Okay. The same thing I'll be explaining in lab evaluation. So clinical features are gone. You know which age group is affected, which sex is affected, the classification. So maximum you have studied. Now lab diagnosis, here out of 15 marks, 7-8 marks will be for lab diagnosis. What are you going to write then? So these are the points. That's how you have to approach basically. Again, exactly this is what I taught you in the last class. This is the only reason why I'm recapitulating again. The last one was both ALL and AML. Now here I have segregated because I'm teaching ALL. I'll be talking on points pertaining to ALL. So in lab diagnosis again, what are you going to study? Peripheral blood smear. The first and foremost thing that you have to study is peripheral blood smear. Next is bone marrow. BME is bone marrow. Then comes cytochemistry, immunophenotyping, cytogenetic and molecular analysis. So at least these 5 things you have to remember. Now, let me tell you something. To classify ALL or AML, even cytochemistry is not the recommended method of choice now, but we have to still teach you. Okay. The minimum investigation that we have to do to classify ALL or AML or any kind of leukemia, it starts at least with immunophenotyping. It starts with immunophenotyping. Then it goes higher up. We do peripheral blood smear, we know that this is a case of leukemia, then we do a bone marrow, but that's not enough. Because necessity is the mother of invention. And in near future, more and more investigations will come out which will help in subclassifying things again. So whatever we do in the lab is ultimately, whatever reports we come out in the lab or whatever we try to derive from the lab should help the patient in some way or the other. For example, in prognosis, in treatment, etc., etc. So FAB does not help in those causes, but WHO classification helps. And to identify and to derive, to rather conclude what's given in WHO, you need at least immunophenotyping, cytogenetic and molecular genetic studies. Okay. Cytochemistry does not help. To be very honest, it does not help much, and I'm going to explain you why. So PBS versus bone marrow. Morning shows the day. Morning shows the day. You know the meaning of the word. Morning shows the day, right? Yes or no? Yes or no? Morning shows the day. So whatever is happening inside your bone marrow is reflected in your peripheral smear. Whatever is happening inside your bone marrow is finally reflected in your peripheral smear. So the WHO recommends, in bone marrow, the WHO recommends blast cell to be at least 25% of all nucleated cells. So of all nucleated cells, the blast cells must be 25%. At least 25% or more. Minimum 25%. Different books give different things, and WHO keeps on changing. So here I'm telling you, at least 20 to 25%. Some books give 30% also. Okay. Marrow is completely replaced by blasts. You know why? Because there is proliferation, excessive proliferation of this blast, which will replace the normal hematopoietic elements. Marrow is completely replaced by blasts, and the normal hematopoietic elements will diminish. That's why patient will present with features of pancytopenia. That's why patients will present with features of pancytopenia. You know, anemia, granulocytopenia. You know, I have explained you the features, thrombocytopenia. So what will happen in peripheral blood smear? Hemoglobin will be decreased, anemia, TLC will be markedly elevated, total leukocyte count because of the blasts, granulocytopenia and thrombocytopenia. The normal elements will be decreased. In differential counts, there will be a lot of blasts. Blast percent will be very high. more than 25% is the cutoff criteria, but marrow elements because, so morphology of the blasts is FAB. This is where FAB classification comes into play. We have three types, L1, L2 and L3. L1, L2 and L3. Hey! Shh. What are you guys doing up there? Morphology. This is something you have to know, at least at your level, you must know the morphology. ALL is small as compared to, so you must look into the size of the cell. For example, these are the points that you must remember. For example, cell size, frequency, you know, ALL, L1, L2, L3, okay, leave that. Come to the cell size. This is what you must know. Cell size. ALL1 is small cells, whereas ALL, L1, ALL, L2 and L3, they are comparatively larger. Then comes cytoplasm, the volume of cytoplasm. Because ALL, L1 is smaller, their cytoplasm will be scanty. Whereas in ALL, L2 and ALL, L3, because the size is larger, their cytoplasm will be moderate. Okay, moderate to abundant, depending on the size, moderate to abundant. Then nuclear clefting. Nuclear clefting will be seen in which one? ALL, L3. There will be a kind of lineator. Nuclear, there will be some clefting in the nucleus. That will be, yes, in ALL, L3, there will be nuclear clefting. There, the nuclear shape. Here, remember, irregular clefting and indentation common. L2 some books have written L3, okay, leave it. The nuclear chromatin. So these are basically the points that you must remember. And based on this, sorry, I made a mistake. ALL, L2 is clefting, whereas in ALL, L3, you'll get cytoplasmic vacuoles. In ALL, I made a mistake, sorry. ALL, L1, ALL, L2 is where you're going to get nuclear clefting, and ALL, L3 is one where you're going to get cytoplasmic vacuoles. So, see this diagram. This is a schematic diagram which will help you to understand, understand the difference between the morphological differences between ALL, L1, L2 and L3. Sorry, again, I'm apologizing. ALL, L2 is the one where you get nuclear clefting, whereas ALL, L3 is the one where you get cytoplasmic vacuoles. The picture is quite clear. It shouldn't be a problem for you to understand. So this is basically the FAB classification where you get three morphological variants, L1, L2 and L3. L1 and L2 and L3, they have some differences among themselves, which has been depicted in a schematic way over here. Okay? Should I go to the next slide? So this is the one which I have explained, cytochemistry and all. I'm coming. So this is basically the cytochemistry. Last class I have explained to you about AML also, myeloperoxidase and all. But in ALL, MPO is negative. ALL is all about PAS. Now I told you in the a few minutes back when I was talking, when I was with the last slide, a few slides back, that cytochemistry is not the recommended method to identify blasts. And the reason is they are quite sensitive, but they are not specific. They are quite sensitive, but they are not specific. Why? PAS in L1 and L2, it's positive. PAS is positive in L1 and L2. PAS is paradic acid shift. Paradic acid shift, remember? Why? Because they identify the glycogen. Lymphoblasts have glycogen, and that is what they identify. PAS identifies glycogen. L1 and L2, it is positive, whereas in L3, it is negative. Remember that. So the positivity will be block-like. Against a clear cytoplasm, there will be block-like positivity. This is known as block-like positivity against a clear cytoplasm. Perinuclear, in and around the nucleus, there will be blocks of positive material. So this is known as block-like positivity, whereas MPO and NAC will be negative. PAS will be positive, but MPO and NAC will be negative. So what kind of positivity PAS shows? Block-like positivity. Block-like positivity. Against a clear cytoplasmic background, the blocks will be, the positivity will be perinuclear, means surrounding the nucleus. Okay, MPO and NAC will be negative. L1 and L2 is positive, whereas L3 is negative. Okay. Now, in why cytochemistry is not the recommended method is, in 30% of cases, L1 and L2 may be negative. L3 is negative, L1 and L2 is positive. But in 30% cases, L1 and L2 may be negative. And in some cases, monoblasts, some myeloblasts and erythroblasts. Myeloblasts, erythroblasts and monoblasts like AML M5, AML M6, AML M7, they can be positive at times. They can be positive at times. So it is sensitive. So this is sensitive. Sensitivity is good with PAs, but it is definitely not specific. Sensitivity is there, but it is definitely not specific. So this is the reason why cytochemical examination is not the recommended method of choice. Okay, if it is positive, it's positive, fine. But if it is negative, then what? Then does it rule out ALL? No, it does not rule out, because in some cases, in 30% of cases, ALL L1 may be negative, and in some cases, some cells of myeloid series, myeloblasts, some monoblasts, erythroblasts like AML M5, AML M6, they can be positive at times. So the sensitivity is there, but it is not very specific. Sensitivity is there, but it is not very. Feeling sleepy? Put some water and come. Not you. Alpha naphthyl acetate esterase, all those other stains are negative. All those other stains are negative. So at least if you don't remember MPO, Sudan black, no need to write. This is for you to understand. At least write PAS is positive. PAS is positive, predominantly block-like positivity. L1 and L2 it's positive, L3 it's negative. But in 30% of cases, L1 and L2 may be negative, and in some cases, myeloid cells of some myeloblasts, monoblasts, and erythroblasts, they can be positive, like AML M5, AML M6, they can be positive. And this is the reason why PAS is quite sensitive, but not specific. You cannot confirm. If it's positive, then it's fine. You clinically, it's ALL. Morphological features are in favor of ALL. Cytochemistry goes in favor of ALL, fine. But in some cases, if cytochemistry doesn't go in favor of ALL, whereas the other features are in favor of ALL, that doesn't rule out that this is ALL. Okay, it's non-specific. Cytochemistry is quite non-specific, so it's not the recommended method of investigation. And that's why, this is what I have explained. We go for immunophenotyping, the last slide. Immunophenotyping. In immunophenotyping, the BALL is again categorized into pro-BALL, common BALL, pre-BALL, mature BALL. So what are the immunophenotyping? So what are the various antigens? In immunophenotyping, what we identify? We identify the antigens by making it react against antibodies, right? So that is the basic principle. So what antigens we get, what basically markers or rather antigens we get on the surface of the, say, pro-BALL cell? TDT, HLA-DR, CD19, they're all positive. Cytoplasmic CYT79A, CD22. They are markers which are in favor, which are seen in pro-BALL, the subtype of pro-BALL. And FAB morphology over here is L1 and L2. L1 and L2. This correlates with FAB morphology L1, L2. Seen most commonly in infants and children, has a good prognosis. Then comes common ALL, which by far has the best prognosis. Here the same markers which you see in pro-BALL, in addition to it, you get CD10. In addition, you get CD10. Break up, man. You like sitting like this? CD20. CD10 is known as common ALL antigen. CD10 is known as common ALL antigen, and this correlates with morphology L1 and L2, seen mostly in children and has the best prognosis. Then comes pre-BALL. The same markers along with cytoplasmic mu chain. It's not U, it's mu chain. Cytoplasmic mu chain. It has poor prognosis. Morphology is L3 probably I haven't mentioned. It has poor prognosis. And mature BALL do means the same markers along with SMIG, surface immunoglobulin. Surface immunoglobulin. So this only remember SMIG, that's more than enough. Only remember cytoplasmic mu, that's more than enough. Common because CD10, which is common ALL antigen. Just remember this once. Just remember these ones, that's more than enough. We'll give you full marks. And it correlates with morphology L3 in FAB and has a very poor prognosis. Okay, so these are the four things you must remember. These are the four things you must remember: pro-BALL, common ALL, pre-BALL, and mature BALL, which has a good prognosis and which has a bad prognosis. Remember these points. So immunophenotyping helps you to identify various antigens on the surface or the cytoplasm or the nucleus of the leukemic cells. And how are they identified? They are made to react with antibodies which are specific to those particular antigens. The method of choice is flow cytometry. Flow cytometry or immunoperoxidase method. Whatever the flow cytometry is the method of choice because the cells are in fluid suspension. Then coming to the cytogenetic and molecular subtypes. Cytogenetic and molecular subtypes. Then coming to the cytogenetic and molecular subtypes. This I have explained you. This I have explained you in the last slide. T922 BCR-ABL, BCR-ABL, Philadelphia chromosome, BCR-ABL fusion gene. This has a poor prognosis. This has a poor prognosis. T1221, TEL bar AML1, it has a good prognosis. Okay, then hyperdiploidy. This is DNA ploidy studies. Hyperdiploidy means more than 50 chromosomes with a good prognosis. Hypodiploidy, less than 50 chromosomes, that has poor prognosis. So remember a few, at least the first two you must remember because that's what I have underlined. See the ones which have put a tick mark on. Eta ami amar PG পড়ার সময় আমি করেছিলাম. So those are the ones because what our teachers used to tell us, I'm telling you the same thing, just passing on generation after generation, that's the thing we do. Okay, so these are the things you must remember. Because do not expect me to put the whole WHO classification for you. It's humanly, you can't remember, neither can I, nobody can remember the entire WHO classification. All those things are needed when we diagnose cases and we use them for references. Okay. Okay, হয়ে গেছে? Done. So coming to the other investigations. Now you know peripheral blood smear, bone marrow, cytochemistry, immunophenotyping, molecular and cytogenetic analysis, but there are certain other investigations which are of prognostic significance. One is lumbar puncture. When you do, lumbar puncture is for what? Lumbar puncture is for what? Cerebrospinal fluid. I've told you, CNS involvement. Testicular biopsy. Testicular biopsy is to rule out MRD. What is MRD? Don't say medical representative and all. Minimal residual disease. MRD means minimal residual disease. Third one is chest X-ray. Thymic involvement, mediastinal mass, seen in more common with ALL. And if it is a case of TALL, it has a poor prognosis. TALL is to a certain extent, it can be seen in adults also. TALL to a certain extent can be seen in adults also. And if the chest X-ray is involved, in chest X-ray, if the mediastinum is involved, if there is a thymic involvement in the mediastinum, this has a poor prognosis. This has poor prognosis. So other than all the common conventional methods which I have told you, please make a mention of these things like the lumbar puncture for CSF to see CNS involvement. Number 2 is testicular biopsy for relapse, MRD in minimal residual disease, and then X-ray chest X-ray to rule out mediastinal involvement. To rule out To rule out prognostic factors. Coming to the prognostic factors, 4 prognostic factors. So divide it in terms of favorable and adverse. Divide it in terms of favorable and adverse. So these are the various prognostic factors. Age, 1 to 10 years is good. He has mentioned 2, okay, 1 to 10 years. Less than 1 year, if it falls in the category of 1 to 10, it has a good prognosis, favorable prognostic category. Whereas 2 to 10, less than 1 year and more than 10 years, the patient belongs in adverse category. Their prognosis is poor. Okay, that is one thing. Sex, gender, I'd rather use the word gender. Females are in favorable prognostic group, whereas males are in adverse prognostic group. Why? Why? Because of testicular involvement. Because of testicular involvement. Okay. Number 3, if the testis is involved. If the testis is not involved, then it's more or less equal. But if the testis is involved, then of course it belongs to a adverse prognostic category. Then number 3, ALL L1 belongs to good prognostic category, whereas ALL L2 and L3 bad prognostic category, adverse prognostic. So these are all the extramedullary involvement. Extramedullary involvement like CNS, mediastinum, testis, which are involved. If they are involved, bad. If they are not involved, good. Total leukocyte count, less than 50,000 versus more than 50,000. Less than 10,000 কেন দিচ্ছে আমি জানি না, but less than 50,000 versus more than 50,000. More than 50,000 is bad. Less than 50,000 is good. Then hemoglobin count, platelet, all those things. Exactly what I've taught you in the last slides. Then you do a immunophenotyping like early BALL, common ALL, they belong to the good prognostic category, whereas mature BALL and all, TALL, they belong to adverse prognostic category. So depends, hyperploidy, around 50 chromosomes, where they have not made a mention of that here. They should have made a mention of that. Okay, hyperploidy versus hypoploidy. More than 50 chromosomes, good. Less than that is bad. So these are the various prognostic markers which you must know, because question has come, so you have to know. End of the story. End of the story. I'm trying to clear the concept. If your concept is cleared, it shouldn't be a problem for you to answer these questions. Exactly how you should write in examination. This is exactly how we expect an answer from you now. Whatever you have put, if you put at least 50% of what I have given, that's more than, you get 80% marks. You put 50% of this, you get 80 to 90% marks. Okay, we don't expect you to write everything. That's humanly not possible. So coming to the risk categories in ALL, we have stratified it into low risk, intermediate risk, high risk, and very high risk. Low risk, intermediate risk, high risk, and very high risk. So low risk is hyperploidy, more than 50 chromosome, and TEL bar AML fusion, means it has a good prognostic, it falls in the good prognostic category. Then comes intermediate risk, age 1 to 10 years. Age 1 to 10 years, TLC count less than 50,000 without genetic risks, without genetic risk factors. Number 3 comes, the high risk comes, age less than 1 year versus age more than 10 years. So that category, age less than 1 year and more than 10 years, TLC more than 50,000 without genetic risk factors. And the last one is very high risk is BCR-ABL, means Philadelphia chromosome, BCR-ABL fusion with high TLC, etc., etc. Okay, stratified into low risk, intermediate risk, and high risk and very high risk, and these are the points which come under each category. So coming to this, just remember this point. Just remember this point. I'm not explaining you. One is remission induction. One is remission induction, where high dose chemotherapy is given to reduce the leukemic blast cells to less than 5%. Okay, so various, like prednisolone, and I don't remember the drugs right now. Pharmacology will be able to tell you better. So first is remission induction, where the main aim is to cut down the blast level to less than 5%. Then CNS prophylaxis. I told you CNS prophylaxis. Why CNS prophylaxis is given? Which category of patients are given CNS prophylaxis? Who belong to a high category? For example, there are blasts in the CNS, or total count is more than 50,000, etc., etc. Low risk category patients are not given CNS prophylaxis for risk of developing complications. For example, various central nervous system tumors. Why CNS prophylaxis is given, you know, because CNS is a site which harbors maximum leukemic cells. This is because when remission induction is given, these particular drugs which are used in remission induction, they cannot penetrate the blood-brain barrier. And because they cannot penetrate the blood-brain barrier, if any leukemic cells harbors itself in the central nervous system, in the CSF, these drugs are ineffective. That's why CNS prophylaxis is given. Now, CNS prophylaxis is not given in each and every patient. Only patients who belong to a high-risk category, they are the ones who are subjected to a CNS prophylaxis because doctors do not risk patients of further morbidity or mortality by developing a central nervous system tumor, which can be a side effect of CNS prophylaxis. So that is number 2. Number 3 is consolidation or intensification. This is also done immediately after. Remission induction. Okay, they intensify the treatment here. Number 4 is maintenance therapy, which is done for around 2 to 2.5 years. This is because I'm not explaining much, because this is not my subject here. Pathology, they will not ask you this question. And the 5th one is supportive care. 5th one is supportive care. So if someone asks you, if the examiner asks you, what are the phases of treatment, that's how you have to go. Remission induction, then comes CNS prophylaxis, given in high-risk patients. Not all patients undergo a CNS prophylaxis. Then comes consolidation or intensification of the treatment. This is followed by maintenance therapy for at least 2 to 2.5 years, and then supportive care. The main aim of therapy is to cut down the blast level to such an extent that normal hematopoiesis is restored. Okay. Finally, so this is the last slide. Minimal residual disease, which I have told you. Minimal residual disease means submicroscopic persistence of blast cells. Some blast cells always persist. No matter how much you treat, some blast cells always persist. Okay, relapse occurs in less than 20% of low risk, whereas more than 70% of high risk cases. Okay, and what is MRD? MRD is basically nothing but the presence of a few viable leukemic cells at the submicroscopic level. That's why it's called minimal residual disease. And which organ is the site for minimal residual disease? Testis. Testis is the site where relapse occurs most. That's why males are affected. Males belong to a bad prognostic category. And minimal residual disease is due to the presence of viable leukemic cells at a submicroscopic level. The most commonly organ involved is testis in case of males. Yes, CNS, it can also occur. And what are the methods of identification? Like FISH, fluorescent in situ hybridization, cytogenetic analysis, same thing, immunophenotyping, and molecular genetic analysis. So with this, I finish ALL. Now I need 2 more classes, which is an unscheduled class to finish AML and CML, chronic myeloid leukemia and acute myeloid leukemia. So let me know when you want the class, maybe not next week, because this is big, and from every category, every leukemia, some questions or the other has come. So I don't want to mix it up so that it becomes easy for you to understand.
Bronchial asthma and COPD both are the chronic inflammatory condition of the bronchial mucosa, characterized by bronchoconstriction. The difference between bronchial asthma and COPD is, in bronchial asthma there is reversible episode of bronchoconstriction, while in case of COPD, it's a non-reversible or irreversible condition where there is irreversible episodes of bronchial asthma. Now, in bronchial asthma, there is chronic inflammatory disease where the patient suffer from reversible episodes of recurrent bronchospasm caused by airway obstruction and due to bronchial hyperresponsiveness. Here the primary pathology is basically allergen exposure that causes reversible episodes of bronchoconstriction. Now it's reversible, but after certain period, the chronic inflammation can lead to irreversible airway obstruction later on, like COPD. Now, what happens in the early phase of bronchial asthma? There is bronchoconstriction due to smooth muscle spasm. Along with that, in later phase, there is excessive secretion of mucus, and this mucus can clog the bronchioles and the bronchus, worsening the attack. In the later phase, the inflammation continues due to the release of inflammatory mediators from the inflammatory cells like mast cells, particularly eosinophils, basophils, neutrophils, and these are accompanied by fibrosis, edema, bronchial wall edema, and necrosis of the bronchial epithelial cells. Now, cardinal symptoms of bronchial asthma are cough, breathlessness, and then wheezing. What is wheezing? Basically, the musical sound comes with respiration, and there is chest tightness. Now, how we diagnose bronchial asthma? By pulmonary function test, we see peak expiratory flow rate, FEV1, forced expiratory volume in first second, and mid maximal expiratory flow rate. These are all decreased. But the gold standard for the diagnosis of bronchial asthma is FEV1, that is forced expiratory volume in first second. Now, in case of arterial blood gas, the arterial partial pressure of oxygen, it decreases in severe attack of bronchial asthma. Why? Because of bronchoconstriction. But the carbon dioxide, partial pressure of carbon dioxide level is initially maintained or may even decreased in acute attack of bronchial asthma because the patient is hyperventilating, and that causes the carbon dioxide wash out. But when the severe bronchial asthma attack continues due to increasing obstruction, the patient is not able to wash out carbon dioxide start to retain, and as such the PA, that is partial pressure of carbon dioxide, it start to increase, and that signifies severe life-threatening attack of bronchial asthma. Now, types of bronchial asthma. Bronchial asthma can be basically of two types. One is intrinsic asthma and the other one is extrinsic asthma. Now, what do you mean by intrinsic asthma? There is a trigger factor. It can be allergen, it can be some chemical irritants. So, extrinsic asthma, that is associated with the exposure of specific precipitating factor like allergen. It can be pollen grains, which can be house dust, mite, and others. While in case of intrinsic asthma, there is no precipitating factor or immunological basis. In extrinsic asthma, the asthmatic attack is episodic. When there is exposure to allergen or the precipitating factor, then only the bronchoconstriction ensues. So it is episodic, while the intrinsic asthma is perennial, that is round the year. Why? Because there is no precipitating factor for it. The extrinsic asthma patients, they are lesser prone to status asthmaticus. What is status asthmaticus? It is a severe life-threatening attack of bronchial asthma. We will come to it later on. Now, intrinsic asthma, they are more prone to develop status asthmaticus. Now, extrinsic asthma can be again of two types. It can be atopic, it can be non-atopic. What do you mean by atopic extrinsic asthma? Here a specific allergen is involved. While in case of non-atopic asthma, the precipitating factor is non-specific, like any chemical irritant or fire fumes. Status asthmaticus, as discussed, is a severe, acute, life-threatening episode of bronchial asthma, and the cardinal features are severe breathlessness. Patient is not able to even speak a sentence. The patient may be hypoxic, may be cyanosed. In the initial phase, there will be severe tachycardia, but in the advanced stage, the patient may develop bradycardia. The patient may develop hypotension, dehydration, metabolic alkalosis. What do you mean by cardiac asthma? Is a basically severe episode of bronchospasm caused by congestive heart failure. There, the pulmonary cause is not there. The cause is mainly heart failure. Then we say it cardiac asthma. Now coming to pathogenesis of bronchial asthma. In case of classical pathogenesis of bronchial asthma, when a patient is first time exposed to an allergen, what happens? The body synthesizes IgE antibodies, which either circulate in the blood or in the mast, or may remain attached to the mast cell. But after this, when a patient is again exposed to the same allergen, what happens? There is antigen antibody reaction, antigen IgE complex formation on the mast cells that causes degranulation of the mast cells, releasing chemical mediators. What are they? It can be histamine, serotonin, prostaglandin D2, and very important, leukotriene C4 and D4. Leukotriene C4 and D4, they are mainly responsible. They are very important chemical mediators for the early phase of bronchoconstriction in the bronchial asthma. Now, after that, what happens? Due to the release of the chemical mediators, there is bronchoconstriction, the inflammation continues. There is release of more and more, there is chemotaxis of inflammatory cells like basophils, eosinophils, and other inflammatory cells. What happens? So there is more and more release of leukotrienes and interleukins. Interleukin like IL-4, IL-5, IL-13, and leukotriene also LTB4. Now, so this further aggravates the inflammation, and particularly eosinophil, they secrete two inflammatory mediators, eosinophilic cationic protein ECP and eosinophilic neurotoxin. What does they cause? They additionally cause shedding of the bronchial cells. So because of the shedding of bronchial cells, there is exposure of the irritant fibers, irritant receptors, and the C fibers. So now the allergen with the hyper responsiveness of the bronchial mucosa due to this, due to the shedding of the bronchial cells, and that is responsible for the pathogenesis. Now, the bronchial tone of a normal human being is maintained by sympathetic activity, parasympathetic activity, along with that NANC, non-adrenergic, non-cholinergic activity. Now, coming to the parasympathetic activity, you see there M3 receptor. M3 receptors, they are present in the bronchial smooth muscles. Now, when due to the parasympathetic stimulation, there is activation of the M3 receptors, which cause increase in the cyclic GMP, and that cause bronchoconstriction. Now, the sympathetic innervation in the bronchial muscles is that is very sparse. They are mainly present in the blood vessels. So these, but the receptors are there. Beta 2 receptors are there on the bronchial smooth muscle, and they are responsive to the circulating catecholamines. Now, when these beta 2 receptors, they are stimulated, there is increase in cyclic AMP, and that causes bronchodilation. Now, coming to the next, adenosine. Adenosine also plays an important role in the maintenance of the bronchial tone. They causes bronchoconstriction by acting on the A1 and A3 receptor. Now, coming to NANC activity, most important is nitric oxide. They causes bronchodilation by increasing CGMP. Now, there are also substance P, neurokinin A. They are causes bronchoconstriction. Now, the thing to say is that histamine is not an important mediator of the acute attack of important mediator of human asthma attack, and so antihistaminics are not that useful in treating of bronchial asthma patients. Again, leukotrienes and interleukin, particularly IL-4, are important mediators of acute asthma attack, and so leukotriene antagonists, they are used for the treatment of bronchial asthma, and the newer bronchial asthma drugs, they are more researching on the IL-4 receptors and IL-4 antagonist. Coming to the drugs used for bronchial asthma, we can divide the drugs used for bronchial asthma in two groups. One is bronchodilator, they reverses the bronchoconstriction, and another group is for prophylactic therapy, which antagonizes the inflammatory action. Now, bronchodilators, they include broad 4 groups: selective beta 2 agonist, which act on beta 2 receptors; non-selective sympathomimetics; anticholinergics, methylxanthines. Now, selective beta 2 agonists, they include short-acting one, long-acting beta 2 agonist. Short-acting beta 2 agonists, they are salbutamol, terbutaline. These two drugs are commonly used. Long-acting ones, they include salmeterol, formoterol. Also, other drugs are there: indacaterol, olodaterol, vilanterol. These are ultra long-acting beta 2 agonists. Non-selective sympathomimetics, they act on other receptors other than beta 2 receptors. So, they include epinephrine, very important, ephedrine, isoprenaline, and oxyprenaline. Now, anticholinergic, that includes short-acting ones, long-acting ones. Short-acting muscarinic antagonists, they include ipratropium, oxytropium. Long-acting muscarinic antagonists, they include tiotropium, glycopyrronium, aclidinium, umeclidinium. Methylxanthines, very important, theophylline is commonly used, aminophylline is there, doxophylline is there, choline theophyllinate, diprophylline. Now, coming to the other group of drugs, they include corticosteroids. They are used for prophylactic therapy of bronchial asthma. They basically decrease the frequency and amplitude of the attack. Corticosteroids, it can be used by oral route, parenteral, and inhalation route. Oral route, prednisone, prednisolone, methylprednisolone, and parenteral hydrocortisone, methylprednisolone. Inhalational corticosteroids, they include beclomethasone, fluticasone, budesonide, flunisolide, cyclesonide. Mast cell stabilizers, they inhibit the degranulation of the mast cells. They include sodium chromoglycate, ketotifen, and neurochromil. Leukotriene modulators, which include 5-lipooxygenase inhibitor, they inhibit the synthesis of leukotrienes. Example is xylitol. And leukotriene receptor antagonist, they include montelukast, gefilukast, eralukast, tanlukast. Monoclonal IgE antibody, they act against IgE antibody, omalizumab, and the miscellaneous, these are basically newer bronchial asthma drugs. They include benzaluzumab, tezepelumab, mepolizumab, dupilumab, reslizumab, nitric oxide donors. Now, acute attack of asthma is reversible by the use of bronchodilator therapy. But the problem is that the inflammation. With every attack of bronchial asthma, the inflammation continues mainly in adult, and for each time there is damage to the alveoli. It is for this reason repeated episodes of bronchial asthma can later on lead to the irreversible damage to the alveoli. So, preventing asthmatic attack is rewarding in preventing gradual damage to the alveoli. তাই জন্য just bronchodilator দিয়ে reverse তো করতেই হবে, but we have to decrease the inflammation so that the lung alveoli are healthy. Now coming to sympathomimetics. Now beta 2 receptor stimulation, as already said, it causes increase in cyclic AMP level in the bronchial muscle cells, causing bronchodilation. Now along with that, beta 2 receptors, they are also present in mast cells and other inflammatory cells. And by acting on these beta 2 receptors present on the mast cells and other inflammatory cells, they cause decrease in inflammatory mediator release. So by this they can act as they have an anti-inflammatory effect. But the problem is that the beta 2 receptors present on the inflammatory cells, they desensitize quickly. So on prolonged use of the beta 2 agonist, the beta 2 receptors on the mast cells and other inflammatory cells, they are not able to act. So on prolonged use of beta 2 agonist therapy, there is no anti-inflammatory effect because the beta 2 receptors have already got desensitized. But the beta 2 receptors on the bronchial smooth muscles, they do not desensitize quickly. And so even on prolonged use, the bronchodilator effect is there. Adrenergic drugs are the mainstay of therapy for the reversible airway obstruction, but should be used cautiously in hypertensive subjects, in patients with ischemic heart disease, and in those receiving digitalis because of the beta 1 effect. The beta 2 agonists are the most effective and the fastest acting bronchodilator in inhalation route. Now non-selective sympathomimetics, the problem with these drugs are they are non-selective. Along with action on the beta 2 receptors, they are acting on the beta 1 receptors, causing cardiac stimulation, causing tachycardia, palpitation, worsening of angina, and even arrhythmia. So their use has been declined. Now coming to epinephrine and isoprenaline, before the advent of beta 2 agonists, selective beta 2 agonists, they were used by inhaled therapy for the treatment of the acute attack of asthma, but nowadays their use has declined. Epinephrine can sometimes be used in status asthmaticus. Why? Along with beta receptor, they also act on alpha receptor. Alpha receptor are present in the pulmonary vasculature, and by stimulating alpha receptor on the pulmonary vasculature, they cause pulmonary vasoconstriction. And so in bronchial asthma patient, acute attack, they reverses the pulmonary edema. So they are sometimes used in severe bronchial asthma patient by subcutaneous route. Now oxyprenaline is a longer acting derivative of isoprenaline with more prominent beta 2 action. The incidence and severity are less, but their use has declined with the advent of selective beta 2 agonist. Ephedrine is a long acting one, but the problem is CNS stimulant action. So they are not used nowadays. Selective beta 2 agonist, they are the mainstay of the modern bronchodilator therapy. It can be short acting like salbutamol and terbutaline. It can be long acting like salmeterol and formoterol. Now mechanism of action of selective beta 2 agonist. There are 4 mechanisms. The very important one is they cause bronchodilation by increasing the cyclic AMP level in the bronchial smooth muscles. Along with that, the second mechanism, they inhibit the release of bronchoconstricting chemical mediators from the mast cells and other inflammatory cells. The third thing is that they inhibit microvascular leakage and they increase mucociliary transport by increasing ciliary action. Now already discussed the beta 2 receptors on the inflammatory cells, they desensitize quickly, and thus on prolonged use the effect is lost, and due to this reason they are not useful. They are not useful for the prevention of acute attack of asthma. But desensitization on the beta 2 receptors on the bronchial smooth muscle do not occur even on prolonged use, and so their bronchodilator effect is maintained on prolonged use. Now short acting beta 2 agonist. Short-acting beta-2 agonist, faster onset of action, quick relief, most effective in reversing bronchoconstriction, and they are definitely preferred in symptomatic relief of bronchial asthma. Both salbutamol or terbutaline are commonly used drugs among the short-acting beta-2 agonists. Now coming to salbutamol, it has got the highest beta-2 selectivity, and this selectivity increases even more on inhalation route. Oral bioavailability, onset of action is 5 minutes, very important, খুব তাড়াতাড়ি কাজ করে, 5 minutes action, onset of action, and the duration of action is around 3 to 6 hours. Oral bioavailability is 50%, duration of action by oral route is 4 to 8 hours. Now, they are not suitable for prophylaxis. Side effects are because of beta-1 receptor stimulation, tremors, palpitation, nervousness, also hypokalemia and restlessness. These are more on the oral route and IV route than on the inhaled route, and they are more on high doses. Terbutaline is similar to salbutamol in properties and use, but it is probably the safer bronchodilator in pregnancy. Long-acting beta-2 agonist, because they are highly lipid soluble, they bind to the beta-2 receptors and does not quickly remove from it. So they are longer acting. Their half-life is much longer, 6 to 12 hours. Now, salmeterol, formoterol, these are some of the examples of long-acting beta-2 agonists. But the advantage with formoterol is that it is longer acting and it is also quick acting, like that of short-acting beta-2 agonist. So the combination of formoterol with inhalational taken for both the purpose, to relieve and to control asthma. তাড়াতাড়ি কাজ করবে প্লাস অনেকক্ষণ ধরে কাজ করবে, quick acting and long acting. They do not treat all the long acting beta-2 agonists. They do not treat the underlying inflammation in asthma. And that is why with every acute attack of asthma, if only the long acting beta-2 agonist is used, what happens? The damage to the alveoli continues, and the attack of asthma, it continues more frequent, and there is even increase in the incidence of the life-threatening asthma. So, long-acting beta-2 agonists, say they should never be used alone, but should always be used in combination with inhalational corticosteroids as fixed dose combination therapy, so that the incidence of life-threatening asthma is not there. They are also used, the long-acting beta-2 agonists, they are also used in combination with anti-muscarinics. Both salmeterol and formoterol, they inhibit the late allergen phase induced asthma, which occur when the action of the short-acting beta-2 agonist is gone. Now coming to methylxanthines. Methylxanthines, they basically are plant products. They include theophylline, theobromine and caffeine. Theobromine, it has got very weak action, so it has got no role in clinical therapeutics. Now coming to the sources of the methylxanthines, these are basically tea leaves, cocoa and chocolate, coffee seeds and cola drinks. In tea leaves, we mainly get caffeine and a small amount of theophylline and theobromine. In the cocoa and chocolate, we mainly get theobromine and some amount of caffeine, and from the coffee seeds and cola drinks, mainly caffeine. Pharmacological action of methylxanthines. On the central nervous system, it has got stimulant effect. So what happens? The patient, the sense of well-being is there, the patient is more alert, it allays fatigue and it improves performance. And these actions are more with caffeine than theophylline. Now, but the higher doses can cause toxicity, causing nervousness, restlessness, panic, insomnia in higher doses, tremor, panic, delirium and convulsion. And higher doses even can cause vomiting. The toxicity are more with theophylline rather than caffeine. Cardiovascular system, it has got positive inotropic effect, so increases contractility of heart. It has got positive chronotropic effect, so increases heart rate. Now, coming to the effect of methylxanthine on heart rate, it may be increased due to the direct cardiac action, it may be decreased due to the vagal stimulation, and the effect is variable, and higher doses can cause arrhythmia. On the blood pressure is increased due to direct inotropic action and vasomotor center, and decreased due to vagal stimulation and vasodilatation caused by beta 2 receptor. Now, usually a rise in systolic blood pressure and fall in diastolic blood pressure is noted, and very important, they cause dilatation of systemic arteries including coronary artery, except cerebral vessels where they cause cerebral vasoconstriction, and this is more caused by caffeine, and it is for this reason that the caffeine find use in the treatment of acute attack of migraine. Smooth muscle, it causes relaxation, and it is more pronounced in the bronchi, in the bronchial smooth muscles, particularly theophylline. Biliary spasm is relieved, and it has got negligible effect on the genital tract, urinary tract, and on the intestine. But the bronchodilation caused by theophylline and methylxanthines, they are lesser compared to beta 2 agonist therapy. Kidney, it may cause mild diuresis. The skeletal muscle, they increase the contractile power. Now this theophylline, they increases the diaphragmatic contractility, and thus they are helpful in the treatment of dyspnea and COPD. Stomach, it increases gastric acid secretion, pepsin secretion. Metabolism, increase basal metabolic rate, and they also, like beta 2 agonists, they also decrease the inflammatory cells release, inflammatory mediator release from the inflammatory cells. Now, how does the methylxanthine act? Number one, they inhibit phosphodiesterase enzyme. There are 11 subtypes of phosphodiesterase enzyme, and they inhibit all of them. Types of the phosphodiesterase enzyme. What does this phosphodiesterase enzyme do? They causes degradation of the cyclic nucleotides inside the cell. Now, what happens? What happens because of the inhibition of the phosphodiesterase 4 isoenzyme present in the bronchial smooth muscles? There is bronchodilation, and there is decrease in the release of the inflammatory mediators. Adenosine antagonism. Adenosine causes smooth muscle contraction. It causes bronchodilation and dilatation of the cerebral blood vessels. It depresses cardiac pacemaker activity and inhibits gastric acid secretion. By antagonizing the adenosine, theophylline opposes all these things. Deacetylation of histone. Actually, the methylxanthine, they activate histidine deacetylase 2 isoenzyme, and because of that, there is deacetylation of the histone protein, and so the inflammatory gene production is decreased. So there is less and there is more anti-inflammatory effect, and they basically facilitate the anti-inflammatory effect of the corticosteroids. They also cause release of calcium from sarcoplasmic reticulum in the cardiac cell in the skeletal muscles. Pharmacokinetics, they are well absorbed orally, 50% plasma protein bound, distributed to all tissues. The important one is they are extensively metabolized in liver primarily by CYP1A2 enzyme. Because of CYP1A2 enzyme metabolism, the inducers and inhibitors, they interact with the theophylline drug. They are eliminated 10% unchanged in urine. Half-life 7 to 12 hours, pronounced inter-individual variation. The important thing is that the metabolizing enzyme of the theophylline, they are saturable. So, on increasing concentration of the theophylline in the drug, the metabolizing enzymes are saturated, and so the kinetics of elimination, it changes from first order to zero order. So, one of the example of the drug having following zero order kinetic is theophylline. they have narrow margin of safety. Headache, nervousness, nausea, gastric irritation, rectal inflammation, these are some of the minor side effects. Rapid IV injection causes precordial pain, syncope and death. Interaction, as already said, CYP1A2 enzyme inducers like phenytoin, phenobarbital, rifampicin, smoking, they increase the metabolism of theophylline and decrease the concentration of it. The CYP1A2 inhibitors like erythromycin, cimetidine, ciprofloxacin, OCP, oral contraceptive pills, they basically inhibit the CYP1A2 enzyme, so inhibit the metabolism of theophylline, increase the concentration, increase the toxicity. Theophylline also enhances the effect of furosemide, hypoglycemics, anticoagulant digitalis. They decreases the effect of phenytoin and lithium. Now uses in bronchial asthma and COPD, apnea in premature infant, and lastly in acute left ventricular failure. Anticholinergics, they act on the M3 receptor, antagonizes M3 receptor, GQ, phospholipase C, IP3, calcium pathway blockade. Thus they cause bronchodilation. They are less effective bronchodilator than beta 2 agonist. Now they primarily act on larger airways or the upper airways, and beta 2 agonists primarily act on the smaller airways. Ipratropium bromide is short acting 4 to 6 hours, while tiotropium is long acting 24 hours. Bronchodilators, among the bronchodilators, anticholinergics, they are the drug of choice. Why? Because already discussed that COPD is an irreversible irreversible condition. Now, even the smaller reversible component of the bronchial airway in the COPD patient, that is primarily due to the parasympathetic tone. So, by using anticholinergics as bronchodilator in COPD, we can reverse even the small reversible component of the COPD patients. So, they are the mainstay of bronchodilator therapy in the COPD patients, not in bronchial asthma patients, where beta 2 agonists are the mainstay of therapy. Combined with beta 2 agonist, inhaled ipratropium bromide causes more marked and longer lasting bronchodilation in severe asthma and COPD. However, long acting muscarinic antagonists, they may show anticholinergic effect, causes urine retention. So they should be used cautiously in patients with benign hyperplasia of prostate. Now coming to corticosteroids. Now we here discussed till now about the bronchodilator therapy. Now what about the inflammatory condition that is continuing in the bronchial asthma? There the corticosteroid play the major role. Now corticosteroid is not a bronchodilator. What does it cause? It inhibits inflammation. It inhibits inflammatory cytokine production. It inhibits the eosinophil, basophil, lymphocyte infiltration in the lung. It inhibits the inflammatory response to the antigen-antibody reaction, inhibits mucosal edema and bronchial hyperreactivity. Now, it produces more sustained and complete symptomatic relief. Now, among the corticosteroids, inhalation of corticosteroid is the first one to be used in a patient of bronchial asthma. Inhalation of corticosteroid can control asthma, avoiding major side effects related to the systemic corticosteroids. ICS combined with, that is inhalational corticosteroid combined with short acting or long acting beta 2 agonists, they are the first choice in chronic asthma patient. Now coming to systemic corticosteroids. The indication of use for systemic corticosteroids are severe chronic asthma, in status asthmaticus condition, in COPD acute exacerbation. These are the three conditions. Severe chronic asthma when not controlled with intensive bronchodilator therapy and inhalational corticosteroid therapy. There very frequent recurrences of the severe asthma attack. There we use systemic corticosteroids. In a status asthmaticus patient, along with the intensive bronchodilator therapy, we use a short acting systemic corticosteroids for a brief period. COPD, a short course of systemic corticosteroid, benefits some COPD exacerbation patients. Corticosteroid with a short period, and for with having a shorter half-life, they are more preferred. Why? Because the HPA axis suppression is lower with this regimen. Now, inhalational corticosteroids, minimal side effect because they are lesser systemic absorption. Most suitable for long-term treatment of asthma. They are not considered necessary for mild and episodic asthma. যেখানে অল্প ক্ষণের জন্য হচ্ছে in the intermittent period the patient is healthy. There we do not use inhalational corticosteroids. We use short-acting beta-2 agonist as and when required. But in case of mild or moderate persistent asthma, first of all we use inhalational corticosteroids in the smaller dose, and when needed we add up long-acting beta-2 agonist. So not considered necessary for mild and episodic asthma, indicated in persistent asthma to decrease the inflammation. Airway inflammation in COPD are not responsive to corticosteroids. Inflammation does not play a major role in COPD patient. The problem in COPD patient is irreversibility. So the corticosteroids, they do not play a major role in COPD patient. They play a major role in asthma patient. Only high dose inhalational corticosteroids are beneficial in advanced COPD with frequent exacerbation, after the patient is on long-acting muscarinic antagonist and long-acting beta-2 agonist. In therapeutic doses, side effects such as dry mouth, oral candidiasis and voice changes may occur, but this can be prevented by use of spacer and by oral rinsing of mouth. After taking each puff, after taking therapy, the patient is asked to rinse the mouth with water and then spit. Now, among the inhalational corticosteroids, cyclesonide, it has got a novel approach. Why? Because of that, the systemic toxicity is very less with it. What happens? It is a prodrug, cyclesonide, and is cleared by the esterases enzyme in the bronchial epithelium to the active moiety. Now, this active moiety, oral bioavailability is less than 1%, and they are extensively bound to the plasma protein in circulation. So, systemic side effect is very less. Now, coming to the budesonide and fluticasone, they have got higher affinity to the glucocorticoid receptor. Inhaled steroids, they are safe in pregnancy. Leukotriene antagonist. Leukotriene antagonists, as the name suggests, they act against the leukotrienes. Leukotrienes are the powerful mediators of inflammation in bronchial asthma patients. Now, what happens? They cause leukocyte recruitment, stimulate bronchoconstriction, and increase the capillary permeability. Now, among the drugs, montelukast and gefilukast is there, which are cysteine leukotriene 1 receptor competitive antagonist. Now, they cause bronchodilation, reduce eosinophil count in the sputum, they suppress bronchial inflammation and hyperreactivity. Episode of bronchial exacerbation are reduced here. Now, they are not used as to reverse the bronchoconstriction, but they are used for prophylactic therapy to decrease the inflammation. They are well absorbed orally, highly plasma protein bound, and they are metabolized by the CYP2C9 enzyme. Half-life 3 to 6 hours for montelukast and 8 to 12 hours for gefilukast. Abdominal pain, rashes, headache, eosinophilia are some of the side effects. Now, Xylitol is the 5-lipoxygenase inhibitor. They inhibit the synthesis of leukotrienes. They block leukotriene C4, D4, B4 action. They are potential to prevent all leukotriene-induced responses. Now, clinical efficacy is similar to that of the montelukast and gefilukast. duration of action is short. The problem is that the liver toxicity, and it is for this reason this drug is not used. Now coming to mast cell stabilizers, of them the prototype drug is sodium chromoglycate. Now as the name suggests, mast cell stabilizers, they inhibit the degranulation of the mast cells. They inhibit degranulation of mast cells as well as other inflammatory cells, possibly by action on the delayed calcium channels. The long-term treatment decreases cellular inflammatory response. It's not again a bronchodilator therapy, it depresses the inflammation. So they are used for prophylactic therapy. They are ineffective in acute attack. They are administered as an aerosol formation. Now uses in bronchial asthma, allergic rhinitis, allergic conjunctivitis. Systemic toxicity is minimal. Ketotifen, along with the sodium chromoglycate like action, they have got weak H1 antihistaminic action. Because of this antihistaminic action, they have got mild sedation, and they are not a bronchodilator. They are used for prophylactic therapy, infrequently used because of sedation property. Omalizumab is an anti-monoclonal IgE antibody. It is a humanized monoclonal antibody against IgE administered by subcutaneous route. Very expensive. It is used particularly in resistant asthma patient with raised IgE level or positive skin test. Now, this is basically a GINA guideline, Global Initiative of Asthma Guideline 2022. Now, it has been suggested as a stepwise therapy. When a patient comes to you, we divide it into different groups. Like in step 1, there is exacerbation of bronchial asthma in basically less than twice a month. In case of step 2, when we suggest step 2 therapy, the patient is having exacerbation of less than 4 times a week, 4 to 5 days a week. So it like that. As the severity continues, more and more step ladder therapy we prefer. In step 1, the patient is put on short-acting beta-2 agonist as and when needed. In step 2, where there is more frequent exacerbation, the patient is put on low-dose inhalational corticosteroid and the short-acting beta-2 agonist as and when needed. When more frequent exacerbations, then step 3 therapy, where low-dose inhalational corticosteroid is combined with long-acting beta-2 agonist, and similarly we add on the other therapy. Newer drugs of asthma, nitric oxide donors, they cause basically bronchodilation and are used in acute severe asthma and pulmonary arterial hypertension. Benralizumab is a humanized IgG1 monoclonal antibody. They bind to IL-5 receptor, antagonizes it on the eosinophils and basophils. They are used as an add-on therapy for severe eosinophilic asthma. Tezepelumab is basically thymic stromal lymphoprotein. It's an IL-2 cytokine. They act against TSLP, and thus they are basically monoclonal antibody. They are used as an add-on maintenance therapy for severe asthma. Mepolizumab is again a IgG1 monoclonal humanized antibody against IL-5, and they are used as an add-on therapy for severe asthma with eosinophilic phenotype, where there is more eosinophilia. Dupilumab is a monoclonal antibody that binds to IL-4 receptor, again on the eosinophilic phenotype or corticosteroid dependent asthma. Treatment of status asthmaticus. Now, status asthmaticus is a severe life-threatening attack of bronchial asthma. Now, the treatment we can divide into two groups. One is general supportive care and another is specific care. General supportive care, they include hospitalization, oxygen therapy, basically NIV, that is non-invasive ventilation, or positive pressure ventilation support as needed, correction of dehydration, metabolic alkalosis, suitable antimicrobial therapy as needed if there is any evidence of infection. Now coming to specific treatment, they include intensive bronchodilator therapy, that is nebulization by salbutamol and ipratropium bromide, and then addition of the either injectable systemic corticosteroid, that is hydrocortisone, 200 milligram IV stat followed by 100 milligram IV 8 hourly, or the short course of oral corticosteroid as the patient tolerate. And then additionally, salbutamol or terbutaline can be given by subcutaneous route, or aminophylline infusion may be considered. Magnesium sulfate may be given, 2 gram IV over 20 minutes. General anesthetics like halothane, they are also used for the treatment of the status asthmaticus in selected patients. Coming to COPD. COPD is the irreversible airway obstruction, unlike asthma, which is basically a reversible airway obstruction. The clinical progress depend whether the bronchitis, chronic bronchitis is prevalent, or the basically emphysema is prevalent. Drugs relieve only symptom without treating underlying pathophysiology, because it's an irreversible condition. এখানে pathophysiology কে hamper করে কোনো লাভ হবে না. So just relief of symptoms. Aim of treatment is to lessen airway obstruction, reduce respiratory symptoms, improve quality of life, and prevent secondary complications like hypoxemia, hypercarbia, infection, cor pulmonale. Treatment options for COPD, very important: stop smoking. By giving vaccination to influenza and pneumococcal, we can prevent the incidence of infections which can precipitate acute attack of COPD. Long-acting muscarinic antagonists, these are considered the most effective bronchodilator in COPD patient, unlike asthma where long-acting beta-2 agonists are there. Current guideline in COPD patient, they recommend combination of long-acting muscarinic antagonists and long-acting beta-2 agonist therapy with add-on therapy with higher dose of inhalational corticosteroids as needed when there is advanced COPD, with short-acting beta-2 agonist as and when needed. Theophylline revifenacin is a novel drug, long-acting muscarinic antagonist. They produce a sustained long-acting bronchodilator therapy, dilatation by nebulization route. The anticoronary side effects are very low with this drug. Systemic corticosteroids may be added only if needed for only very brief period of time. Domiciliary oxygen therapy in hypoxic patient. The patient may be given oxygen at home where there is advanced COPD, persistent hypoxia is there. Use of mucolytics and expectorant are controversial in the treatment of COPD. Cough. Cough is a protective reflex. What happens? By coughing, we get rid of our basically excessive mucus and bronchial secretion. So the purpose of cough is expulsion of respiratory secretion and also foreign particles. Occurs due to stimulation of mechano and chemoreceptors in the bronchial epithelial, in the throat and respiratory passages. The causes of cough can be infective, viral, bacterial, fungal, can be inflammatory, can be carcinoma, bronchogenic carcinoma, intractable cough is there, can be cigarette smoking, smoker's cough, can be drug induced, particularly ACE inhibitors, acetylcysteine, we will come there. Amiodarone is an antiarrhythmic drug, inhaled medication, and iodine. Types of cough. Cough can be productive, which is useful. It is helpful in getting rid of excessive mucus and bronchial secretion. And dry cough, which is useless. Now, productive cough, they serve to drain the airway. So they are beneficial. and so suppression of the cough, productive cough, is not desirable and may even be harmful. Dry cough, they are useless, they are often more troublesome and should be suppressed if the patient is more distressing or if the consequence of persistent cough are serious, like in case of post-surgical patient, like in case of cardiac disease. Now, these are the drugs used in patient of cough. It can be antitussives. What does they cause? They cause either suppression of the cough center in the brain, or they decrease the tussle impulse in the respiratory tract. It can be centrally acting, it can be peripherally acting. And again, there is expectorant. What does they cause? They either decrease the viscosity of the bronchial secretion or increase the expulsion. Now, antitussives, these are centrally acting, which can be opioid, non-opioid. Opioids are codeine, polcodeine, ethyl morphine. Non-opioids, noscapine, dextromethorphan, prenoxdiazine. Peripherally acting, benzonatate. Benzonatate is both central and peripherally acting. Pharyngeal demulcents like lozenges, like syrups, glycerin, licorice. Steam inhalation. Adjuvant bronchodilator, salbutamol, terbutaline. Now, expectorant secretion enhancers, they increase the bronchial secretion. Guaifenesin, potassium iodide, potassium citrate, ammonium chloride, toluolfenum and Wasaka. Mucolytics, they decrease the viscosity of the bronchial secretion. Bromhexine, ambroxol, carbocysteine, acetylcysteine. Now, among the expectorant, the US, United States FDA, has approved only guaifenesin as expectorant, none other. So, only guaifenesin is marketed in USA as expectorant. Antitussive, they act in the CNS, either they raise the threshold of the cough center, that decrease the cough, or they act peripherally in the respiratory tract to reduce the tussle impulse. They should be used only in dry cough if it is distressing to the patient or may be harmful. Opioid antitussive, morphine and its congeners are the most effective antitussive. But the problem with morphine is that they have got addictive liability and respiratory depression. So they are not used. Codeine, it is more selective for the cough center, lesser addictive liability, but at higher doses, respiratory depression and drowsiness may occur, particularly in children. So they are contraindicated in asthmatics and in patients with decreased respiratory reserve and should be avoided in children. Now, ethyl morphine, it has got antitussive and respiratory depressant action like that of codeine. But they are less, codeine, they are more constipating. So, always to be added laxative when a patient receives codeine. Now, this ethyl morphine, they are less constipating. Polcodeine, similar to codeine but longer acting with no analgesic and no addicting liability. Non-opioid antitussives, they include noscapine, dextromethorphan, clofedienol and prenoxdiazine. They are basically centrally acting antitussive. They increase the, they basically depress the cough center in the brain, and they have got, as the name suggests, they are non-opioid, so no addiction and basically no respiratory depression. Dextromethorphan is a synthetic central acting NMDA receptor antagonist. Now, although it is non-opioid, no addiction liability is there, but certain drug abusers indulge in it. Pharyngeal demulcent, they coat the pharynx and produce soothing effect. So they are useful in cough above the larynx. Now they produce symptomatic relief of cough. They may be used as and when needed, lozenges or the syrup glycerin. Benzonatate, they are central as well as peripherally acting antitussives. structurally related to local anesthetic tetracaine. So they have got weak anesthetic action as well. Steam inhalation is the most economical because it is present in every home. It's most economical and safe method. What does it cause? It causes decrease in the viscosity of the bronchial secretion. They are useful for cough originating below the larynx, and they are highly useful in bronchiectasis patient. Bronchodilators reduce the cough if it is associated with bronchospasm. Antihistaminics like diphenhydramine, dimenhydrinate, promethazine, particularly H1 antihistaminic, they decrease the cough particularly because of their sedative action. So they are not, sedative effect is not desirable, and even they dry up the bronchial secretion. So they are not commonly used. Local anesthetics such as lignocaine, they are administered by nebulization in the intractable cough due to bronchogenic carcinoma. Even the endoscopes which are inserted in the patient while examination, they may produce cough. So they prevent cough during instrumentation such as endoscopies. They are used as lozenges for intractable cough and painful acute sore throat. Hydration. Maintaining adequate hydration reduces the viscosity of the bronchial secretion. It is recommended to take plenty of water in a patient having cough with tenacious sputum, thick sputum. Expectorant. They are believed to increase bronchial secretion, so that is secretion enhancers, or they reduce the viscosity of the bronchial secretion, that is mucolytic action. Mucolytics are especially useful in patients with tracheostomy with asthmatic bronchitis. Now secretion enhancers, they include sodium potassium citrate, they increase the bronchial secretion by salt action. Potassium iodide, they reflexly increase the bronchial gland secretion. Guaifenesin, Vasica, tolubalsam, they are plant products. Ammonium salt are nauseating and they reflexly increase the respiratory secretion. Bromhexin is basically a mucolytic. It is a derivative of the alkaloid vasicin obtained from Adatoda vasica. What happens? They depolymerizes the mucopolysaccharides in the sputum, and by liberating lysosomal enzymes. So the network of fibers in the mucus, they are broken down, and thus the viscosity is decreased. They are particularly useful in patients having mucus plugs. Rhinorrhea, lacrimation, gastric irritation, nausea, they are some of the side effects. Ambroxol is a metabolite of bromhexin having similar action. Acetylcysteine, they opens disulfide bond in the mucoproteins in sputum, and thus they decrease the viscosity of the bronchial secretion, administered orally as well as by inhalation route. In intubated patient, the acetylcysteine can be directly inserted into the tube. Gastric mucus barrier may be bridged, so they are not used in patient of peptic ulcer patients. Nausea, vomiting, bronchospasm may be produced. Carbocysteine, they act in the same way as acetylcysteine. They are administered orally, not used in patient with with peptic ulcer. Sorry. Thank you.